Welcome to the 7th module of Kerala Society of Ophthalmic Surgeons Scientific Committee CME series. It's my pleasure to welcome all of you to this meeting. And this meeting is being organized by Cochin Ophthalmic Club for Kerala Society of Ophthalmic Surgeons. First of all, let me invite our dear President of Kerala Society of Ophthalmic Surgeons, Dr. Arup Chakravarti, to this meeting. Dr. S. Shashikumar is the President of Cochin Ophthalmic Club. I invite him. He'll be presiding over this meeting. And Dr. Thomas Arun is the General Secretary of Cochin Ophthalmic Club. He is there for the meeting. Dr. N.S.T. Raju, Dr. Rashmin are guest speakers. Dr. Rashmin Gandhi, Dr. Pradeep Sharma, Dr. Virender Sachdeva, Dr. Ambika, Dr. Vijayaraghavan, and our own Dr. M.V. Francis, Dr. N.S.T. Raju. All the delegates, I welcome you all to this meeting. And as I said, this is our 7th module in the series of Scientific Committee, KSOS Scientific Committee CME series. All the 6 done before this were extremely popular. All except one crossed 1,500 views, and actually the one that we did with Palgat, the combined view was more than 3,000. Because there was a practice management aspect also to it. I now request President of Cochin Ophthalmic Club, Dr. Shashikumar, to take over and preside over this meeting.
So, Dr. Srini, warm welcome to the President of KSOS, Dr. Arup Chakravarti, Secretary of COC, Dr. Arun, senior members of the profession, Dr. N.S.D. Raju, Dr. Francis, Dr. Rashmin Gandhi, and all other faculty members. We should congratulate the present KSOS team led by Dr. Arup and Dr. Srini for bringing out this wonderful CME series. KSOS has always been in the forefront in the academic and the social front of ophthalmology in Kerala and also as well as in India. The past 6 CME series has been conducted very well, and it has been appreciated by the ophthalmologists all around India. And this present CME, the scientific content is nicely organized by our secretary, Dr. Thomas Arun Varghese, and the scientific committee chairman of KSO is Dr. Srini Adeklon. They have included all the common topics that is of interest to even the comprehensive ophthalmologist, like emergencies, the pupil, the optic neuritis, the recent advances, Cranial Palsies. All those important topics have been included in this CME. I am sure that this will be of great use to all ophthalmologists, all postgraduates, general ophthalmology, and those who are interested in neuro-ophthalmology. With these few words, I welcome all the faculty and the delegates for this meeting. And I wish that all of you will have a very fruitful exchange of information from this CME. Over to the next proceedings.
I request Dr. Arup Chakravarti to deliver the inaugural address. Sir.
Thank you, Srini, and a very good morning to you all. I would like to thank Cochin Ophthalmic Club for giving me the honor to inaugurate this CME and welcome the web delegates. On behalf of Kerala Society of Ophthalmic Surgeons, KSOS right now is just beyond the halfway mark of the first year tenure. We took over in November 2021. And we are really gearing up to organize our annual meeting that's going to happen in Kozhikode in the last weekend of November, this year end. We are also, after the AIOS physical meeting that happened very successfully, and KSOS won a lot of awards, and I'd like to congratulate all the award winners and the presenters who did so well during this annual meeting. Cochin Ophthalmic Club has been a very vibrant organization. Right from the time I came into, I settled down and made Kerala my home. I've been noticing the Cochin Ophthalmic Club performance. They are very, very active in academics, in social activities, and anything you tell, anything you name it, they are involved in it. And they have also thrown up leaders to lead the KSOS organization to organize annual conferences. Their state conferences are one of the best that they were held in the state of Kerala. So I think this is a place where a lot of talent is there, a lot of talent gets the bloom, and we have great youngsters, elderly people, the past presidents. Dr. Raju is here. We have learned a great deal from Dr. NSD Raju in all aspects as to how to conduct meetings and how to go about things in general, the protocols and SOPs, etc., etc. I would also like to thank my co-office bearers, Dr. Gopal Pillai, the vibrant secretary of KSOS, who is absolutely hardworking. I see his commitment towards the cause, not only his personal teaching responsibilities and admin responsibilities, but the way he has been spearheading various academic movements, like for the classroom, and then being present in the journal club for the postgraduates, in addition to conducting the GBs at the executive committee meetings. It is really commendable. And then last but not the least is our own Srini, who is extremely vibrant, who is full of ideas, bubbling with ideas and energy. And this is the 7th CME of the series. He has planned to organize, I think 11 CMEs, Srini? 12 CMEs across the district, and this is his 7th CME. And these CMEs are very well coordinated, very well organized, and they are all recorded in the channels, and they are also uploaded in the website that we have, KSOS on demand. So if somebody is not able to watch it fully, or is not able to watch it at all, then he or she can always go back and go through the program, the entire details that happened during this program. So Srini has been doing wonderful work, and then he is also planning to broad-base it. Now we are emailers, etc., confined to only Kerala. We are going to broad-base it so that our efforts reach out pan-India, and they really deserve to. With the kind of speakers that we have, virtual who's who in the field of neuro-ophthalmology, it should definitely reach out to an all-India level. So Srini, please, he has plans to fast-track it, and we are all behind him for this gesture. We are also very, very engaged in our, fulfilling our responsibilities to the society. We have an eye literacy program where we have a plan of interviewing most of the senior ophthalmologists who have seen it all and who know how to do it properly. And they interview on various social aspects. And these are actually like TikTok-like movies, they split up into small segments, and this is mainly for the education for the public. This also is going on extremely well with the help of our digital media marketing strategies. And I think KSOS has really been doing quite well, very happy with the progress. As regards the current program, it is, as I mentioned, it is a virtual who's who. I saw our own Francis MV, who has taken headache to a new level altogether. And then we have Dr. Rashmin Gandhi, a very close friend of ours. We have none other than Dr. Shikha Bassi. A smile from you, Shikha. Yeah. And many more will be joining us shortly. We have the dynamic Prashobh, and we have Sujitra, our secretary, president of Cochin Ophthalmic Club. So wish you all the best, and I'm sure going to have a great time enjoying this and learning from this webinar. Thank you so much.
Welcome, Dr. Ambika, Dr. Virender, Sachdeva. They have also joined, Arif sir, and Dr. Pradeep Sharma will be joining shortly now. Next, I invite our scientific committee member, Dr. Prashobh, to say a few words.
Thank you, Dr. Srini. Now it's June, and the children have joined school again. And similarly, KSOS is back to academics after the short break that was AIOC. The whole concept of the CME series and the modules the whole thing was conceptualized by the scientific committee under the able leadership of our chairman, Dr. Srini, and it has been executed. This module in particular has been executed by COC under the leadership of Dr. Thomas Varghese. And I'm sure this will be a wonderful CME, and it will be full of practical points and take-home messages for all, not just neuro-ophthalmologists, but also general ophthalmologists. I'm sure the audience will love watching this CME. All the best.
Thank you, Prashab. Now, the word of thanks by Dr. Arun, and we'll start the scientific program sharp at 9 o'clock. Dr. Arun.
Good morning, everyone. I'd like to my duty is to thank everyone for this attending this meeting. I first like to thank our President, Kerala Society of Ophthalmic Surgeons, Dr. Arup Chakravarti sir, for kindly agreeing to inaugurate our ceremony, our CME. I thank my president, Cochin Ophthalmic President, Dr. S. Shashikumar, for all his guidance and leadership in conducting the CME. A special thanks to Dr. Srini, Scientific Committee Chairman, Kerala Society of Ophthalmic Surgeons, and Executive Committee members of KSOS, especially Dr. Prashab, for all the encouragement and support, especially with the technical matters. A special thanks to all the faculty. I'd like to mention all the faculty, Dr. Vijayaraghavan sir, Dr. Pradeep Sharma sir, Dr. Ambika S, Dr. Rashmin Gandhi, Dr. Shikha Bassi, Dr. Virender Sachdeva, and Dr. M.B. Francis. We have national faculty, and as Arup sir has mentioned, this is the who's who of Neuro Ophthalmology, and we are indeed looking forward to your keynote. A special thanks to the senior ophthalmologist, Dr. N.S.D. Raju sir, Dr. Padmaja Krishnan, Dr. Revati Ganesh, Dr. Nina R, Dr. Matthew James, Dr. Sandhya Somasundaram, Dr. Donna Matthew, for kindly agreeing to present cases and taking part in the panel discussion. A special thanks to all those who have taken time on the Sunday morning to attend the CME. I hope it will be a very useful to all of you, and we have made sure that it is something that it will be of relevance to, or even all comprehensive ophthalmologists, including myself. I consider myself as a comprehensive ophthalmologist with special interest in neuro-ophthalmology, because we really cannot exclude the fact that we are all comprehensive ophthalmologists at the end of the day. So thank you all, and all those who are watching it, for kindly taking your time for attend this meeting, and hope we are all enriched by the end of this. Thank you.
Thank you, Dr. Arun. So we come to the end of the inaugural program, and Dr. Lakshmi and Dr. Karthika will be comparing the whole program, and request them to take over.
We need to introduce Lakshmi and Karthika too.
Dr. Arun?
Yes. Yeah, Dr. Lakshmi, they will be starting the program now.
No, introduce Lakshmi and Karthika.
Yeah. I'd like to introduce Dr. Lakshmi J, who's consultant ophthalmologist at the Giridhar Eye Institute, and Dr. Karthika Mohandas, ophthalmologist at Dr. Tony's Specialty Eye Hospital, who will be comparing, kindly agreed to compare for us, and I hand it over to them to take over the program. The program is designed as 4 sessions, 4 one-hour sessions, each session with 2 keynotes and a few case presentations, and we hope we'll have a good panel discussion, because case presentation is finally what we all learn from. Over to Dr. Lakshmi and Dr. Karthika.
Good morning, everyone. We move on to the first session of today's CME. The session will be chaired by Dr. Francis MV, who is the founder-treasurer of Headache Society of India. He is the reviewer, Indian Academy of Neurology. He has authored books on neuroimaging in headache disorders, and also a free paper evaluator of AIOS. The panelists for this session are Professor Dr. Padmaja Krishnan, Dr. N.S.D. Raju, and Dr. Rashmin Gandhi. The first keynote address will be given by Dr. Shikha Bassi on survival in neuro-ophthalmology. She's working with Medical Research Foundation, Shankara Nethralaya, as Deputy Director, Neuro Ophthalmology Services. Her areas of interest include OCT in Neuro-Ophthalmology, optic nerve head drusen, optic neuritis. She is a recipient of SD Athavale Award at the APAO AIOS 2013, Best Poster Award in Cataract Analysis Catalyst in 2017, IIRSI Gold Medal in 2017. She is the organizing secretary of many national and international conferences, reviewer of many journals like IBMC, Neurology, etc., and has many national and international publications. Welcoming Dr. Shikha Rajesh Bassi for her keynote address.
Thank you for the kind introduction. Can I share my screen?
Yes.
I think you'll have
Let me unshare your.
Yeah. Dr. Francis sir, would you like to say a few words? Francis sir.
Okay. Good morning, everyone. Am I audible?
Yeah.
Okay. So, thank you very much, Dr. Arun, and KSOS President, Secretary, and Scientific Committee members for organizing this excellent Neuro-Ophthalmic Symposium. I know how much time Dr. Arun has put into this program. And I also thank for inviting me to chair this session and also to talk on visual hallucinations. Now we have the first keynote address. We begin this symposium with a talk on survival in neuro-ophthalmology. Keynote address by Dr. Shikha Bassi from Shankara Nethralaya. You know, this is a very fascinating topic for us. And we know how difficult it is to tackle neuro-ophthalmic cases. So she will be highlighting on essential diagnostic and management tips when different neuro-ophthalmic cases present to us in a daily practice. So with these introductory words, over to you, Dr. Shikha.
Thank you, sir. Thank you. At the outset, I would like to thank Dr. Arun KSOS for giving me this opportunity to talk about survival in neuro-ophthalmology. So I've been asked to talk about the basic signs and symptoms in neuro-ophthalmology, which a general ophthalmologist should not miss. The usual symptoms in neuro-ophthalmology that the patient presents with are sudden vision loss, double vision, drooping of eyelids, involuntary ocular or facial movements, pain on combing or chewing, sudden or a new kind of headache, unilateral glare, at times tinnitus, epistaxis with ocular signs and symptoms, at times neurological, sensory or motor weakness with ocular signs and symptoms. Now, out of these, it's very unlikely that somebody will miss the diagnosis when the patient is presenting with sudden vision loss, double vision, drooping of eyelids, involuntary ocular facial movements. Usually, everybody is able to diagnose. Some amount of diagnosis is possible. But with the last 5, you can easily miss the diagnosis. So a detailed history taking and evaluation as well as investigation for the last 5 are important. Now we are going to look at each of these symptoms and combine them with different signs. Now a sudden vision loss can present with all of these. Patient can present with sudden vision loss with a normal fundus, unilateral disc edema, bilateral disc edema, unilateral or bilateral neuroretinitis or optic atrophy. Out of this, if the patient has presented with unilateral or bilateral disc edema or neuroretinitis, you can see, you know that the patient has an inflamed optic nerve or something is happening in the optic nerve. It's very important that you refer the patient to a neuro-ophthalmologist as soon as possible because the time lost is neuron lost. Or if you're sure, treat it. In case of an elderly patient, do an ESR or CRP immediately to rule out a GCA. Now we look at cases. Now somebody presenting with normal fundus in one eye, normal fundus in both the eyes with unilateral vision loss. Now, how to go about this? In such a situation, looking at the pupils is very important. Now, right pupil was sluggish, left is reacting. So we're going to elicit RATV. Patient has a normal fundus and complaining of decreased vision, right eye. This is dilating, left is constricting, right is dilating, left is constricting. So the patient has a relative apparent pupillary defect in the right side. Fundus was normal. Patient has something going on in the optic nerve on the right side. I confirmed the diagnosis by doing a VEP. And the VEP is indeed showing delayed latency with reduced amplitude. I confirm by doing an MRI and it shows optic neuritis on the right side. Now, when the patient presents with bilateral vision loss with normal fundus, the vision loss could be equal. The affliction of the optic nerves could be equal on both the sides. So relative apparent pupillary defect may not be there. So you do a visual fields. And it gives a lot of information. In this particular case, the patient has a bitemporal hemianopia because of chiasmal compression. You can see the chiasm getting compressed by this mass lesion, which is a pituitary adenoma. So the take-home message is always do a visual field examination in case of unexplained vision loss. Let's look at some cases of bilateral disc edema. Now, this middle-aged lady is presented with a swollen disc. Obviously, the margins are blurred, the vessels are getting obscured, there is exudation at the disc, there is dilatation of the capillaries at the surface. So the patient has true papilledema, patient had fulminant IIH. Let's look at another case. Again, the discs are swollen, the margins are blurred, but look at the vessels are tortuous, and there is a hemorrhage here. There are watermark signs, there are island striae. So we are looking at an elevated disc with fuzzy margins, basically. It's a case of chronic papilledema. So be it acute or chronic papilledema, patient presents like this, we have to do MRI of the brain and orbit. If the patient has IIH, you will typically see this denting of the posterior lobe at the level of optic nerve. Do order MR venogram if you are suspecting IIH. Let's look at another case of swollen disc. This is also pretty much elevated with fuzzy margins, palish disc. Look at the blood vessels, they're straight, there's no tortuosity. It's a lumpy, bumpy disc, and with the drusen evident on the surface, there's in fact the peripapillary CNV mode. So we are looking at a case of optic nerve head drusens. In such a case, you don't need an MRI. You can do an ultrasound. You can do CT scan to confirm the drusen. And if you have an EDISD OCT, you can directly localize the drusen. Now we're going to look at a few cases of optic atrophy. We are concerned with non-glaucomatous optic atrophy. This elderly lady, she was complaining of decreased vision for past 8 months and was getting treated as glaucoma for 4 months. She had become blind in the left eye. She had a vision of only counting fingers 50 centimeters, and IOP was normal. I don't need any other test in the eye, just an MRI, and there is an olfactory groove meningioma there. Another case of bilateral optic atrophy, let's try to see what information we get from this image. These are obviously small crowded discs. There is a superior sectoral pallor. You do the visual fields, there is an inferior arcuate in both the eyes. I do the OCT, the superior RNFL is thin. So this is a case of non-arthritic ischemic optic neuropathy. Sometimes patient presents with just bilateral temporal pallor. Could be because of ethambutol toxicity, that is toxic optic neuropathy, can be nutritional optic neuropathy. And you'll see that just to compare it with sectoral pallor of any ION, here its superior half is pale, here the temporal half is pale. Now let's look at the symptom of double vision. As a neuro-ophthalmologist, our duty is to pick up an concomitant squint. That is dangerous. So this 34-year-old lady, otherwise healthy female, has come to us with sudden onset diplopia 3 days. There is a left esotropia. And what is important is that the left eye is not going out. Alternating simple esotropia with full EOM, we are not concerned. But if there is a abduction limitation, there's a case of left six nerve palsy. And what did she have? She had an aneurysm of the left cavernous ICA. She was referred to an interventional radiologist, underwent coiling. Now, children usually present with esotropia. We know congenital esotropia is so common, sometimes can get decompensated. This girl presented with a headache and sudden onset esotropia. And other tests were normal. She had a left face turn, and EOM, again, there is an abduction limitation. So we need to localize the limitation of movement and clinch the diagnosis of cranial nerve palsy. She had a pilocytic astrocytoma in pons. Now, coming to the diagnosed symptom of drooping of eyelids, this elderly lady has come to us with gradual onset drooping of the right eyelid, and you lift up the ptotic, ptotic eyelid, and there is an isochoria with the affected pupil being larger than the other pupil. And she also had limitation of adduction, elevation, and depression. So in such a case, you have to rule out compressive lesion of the third nerve. In compressive lesion of third nerve, before lifting up the ptotic eye, make the patient look towards right and left side, up and down. Here you can see the ptosis is disappearing when the patient is looking towards the left and also while looking down. So there is a inverse Duhansen pseudo-von Graf sign, which are aberrant, signs of aberrant regeneration of third nerve. When we are talking of ptosis, we have to talk about ocular myasthenia. So make the patient look down and suddenly look straight. So this is how focal slit twitch is elicited. You can also lift up the affected eye and the other eyelid comes down. That is the lid curtaining sign. Now, we should also look at the patient's face in toto. You have to look at the skin changes, associated red eye, and anomalous head posture. Red eye, when associated with neuro-ophthalmic signs, it indicates there is some infection which is creeping from eye to the brain. Now, let's try to pick up some signs here. Very obviously, there is herpes zoster ophthalmicus scar on the skin. There is conjunctival congestion on the right side. And there is moderate ptosis and isochoria with obvious limitation of the movements in all directions, all gazes in the right eye. So the patient had a pupil involving right, third, fourth, and sixth nerve palsy because of an enhancing soft tissue lesion on the right superior orbital fissure and cavernous sinus. Again, I said red eye with limitation of movements or other neuro-ophthalmic signs indicates something is happening in the brain. The patient had a dilated superior ophthalmic vein, and patient had, left side, patient had CCF, keratoconus fistula. This lady is an uncontrolled diabetic, and she has again multiple cranial nerve palsies, which is progressing very fast. It is associated with conjunctival chemosis, redness, swelling. So this is a very dangerous sign. Patient had fungal granuloma in the SOF area and cavernous sinus area, and it turned out to be a case of mucormycosis. Now, there are certain benign conditions in neuro-ophthalmology also, like Adie's pupil. This is a mid-dilated pupil, which shows vermiform movements on slit lamp examination. And if you want, in this anisocoria, the mid-dilated pupil constricts with dilute pilocarpine, as can be seen here. There's no particular treatment required for this situation, but the same cannot be said for the another pupillary abnormality, that is Horner's syndrome. I would like to share this case in detail with you. This gentleman, 46-year-old, came to me with complaints of burning sensation on the right side of face associated with decrease in vision. And there was no actual decrease in vision. Patient was 6'6", orthophoric, EOM, and all was full. And all he had was a subtle ptosis, 2 millimeter of ptosis and 2 millimeter of anisocoria with burning sensation. So he had a painful Horner syndrome. On this basis, we sent the patient for MRI, brain with head, neck, and chest, along with MRI. And the patient indeed had a distal cervical internal carotid artery focal dissection, after which the patient was sent to the interventional radiologist. Now, a few involuntary movements of the face. Here you can see there is twitching of the muscles supplied by the facial nerve. So this is a case of right hemifacial spasm. Obviously, we should image the facial nerve. We should do neuroimaging with MRI in these cases. In contrast, this lady has bilateral blepharospasm. There is involuntary contraction of the orbicularis, and it can be because of local cause. As you can see, her cornea is chronically irritated. The neuroimaging is not as important as in case of hemifacial spasm. So with that, I think this is my last case. I would just like to share, this is a case of traumatic optic neuropathy, 8 months old. He had optic atrophy. There's limitation of movement of left eye in abduction. What was important was that, most important thing was that for past 3-4 months, he was keeping this cotton plug in the nose, and he had this chronic epistaxis. So we did an MRI, and indeed there was a large pseudoaneurysm arising from the cavernous internal carotid artery, confirmed with MRA and also with DSA, and patient was successfully treated with coil embolization, which saved his life. I think this is my last slide. I will stop with that. Thank you.
Okay, thank you, Dr. Shikha. That was an excellent talk covering almost all aspects of neuro-ophthalmology. Simple and well explained, with a lot of tips and take-home messages. I have a question to you. I didn't see any CT scan. Do you go for CT scan?
I did show for drusen, optic nerve head drusen.
Oh,
I did
okay.
show a CT scan, but yeah, in traumatic optic neuropathy, certain times we
Thank
do,
you.
and for osteopetrosis in children, to look at the bone health, we do.
Even if you see clinically drusen, you still go for CT to confirm?
No, I did show 3 options. You can choose from any of those, starting with ultrasound, OCT. Now OCT is being used to diagnose optic nerve head drusen. So CT scan was indeed a thing of past, I think, for optic nerve head drusen.
Anyone, Dr. Raj? Any more questions from the panelists? Dr. N.S. Raju, Dr. Padmaja? Okay, then we move on to the case presentation by Dr. Arun Thomas. I think he will be presenting one case now. Dr. Arun.
The first case presentation followed by panel discussion by Dr. Thomas Arun Varghese. He is a consultant in glaucoma and neuro-ophthalmology at Alfonsa Eye Hospitals, Pala and Todupuzha, and St. Joseph Eye Hospital. Over to you, Arun, sir.
You can stop sharing, Kartika. Am I visible, Kartika? Yeah. Okay.
Yes, sir.
Good morning, everyone. Good morning, Chairman Francis, sir, and panel, and all the respected faculty. I would like to present to you a short case. So, this is a 49-year-old resort owner with a complaint of decreased blurring in the right lower half of the right eye field of vision for last 6 months. How he noticed this, like when he was driving or when he was reading the newspaper and he's coming to the lower right corner, especially when reading a newspaper, he felt that was getting blurred. And that's why he realized the blurring in the right eye. And this is gradually getting worse. This was during COVID times, so he tended to delay the consultation and finally decided to come. The other relevant history is a hypertensive for 4 years on treatment with a nocturnal antihypertensive tablet. No history suggestive of obstructive sleep disorder. No history of trauma no history of use of sildenafil or similar medicines, and no history of COVID. As you know, there are some cases of report of field effect following COVID positivity. Ocular examination, vision was 6/6 both eyes, IOP 16 within normal limits, and CCT was within normal limits. And this was the fundus examination. Although the fundus photograph is not very obvious, what could be seen was a superior RNFL defect in both eyes. In the right eye, seen both on the color photograph and on the red-free photograph. We did the field test, which showed a right inferior altitudinal hemianopia, and we did the OCT RNFL, and the OCT RNFL confirmed the fundus finding of the superior RNFL defect in the right eye. Left RNFL was normal. To summarize the findings, so we had a patient with a right inferior altitudinal hemianopia, unilateral, just in the right eye. And so the differential diagnosis we considered were these. Possibility of AAON, especially with this history of taking a nocturnal antihypertensive, possibility of glaucoma, drusen, and posterior ischemic optic neuropathy. You can also get an altitudinal defect with the vascular occlusion, but obviously there was nothing on the fundus to explain that, to suggest that. So we went through the history again. His history was a 6-month history. Typically in AAON, you get a sudden onset, a few days or maybe a week history of blurring. And also in the acute AAON, we get disc edema, which was not present. And in the long-standing or old previous, like Dr. Shikha had shown, previous AAON, you get a pallor corresponding to the field effect. And again, there was the disc appearance was normal. He only had the RNFL defect and no disc changes. Other possibility is glaucoma. Again, there was no disc notching or cupping corresponding to the field effect. And optic disc drusen, Dr. Shikha again had shown there is no lumpy bumpy appearance, and there was normal vasculature. Typically, you get an abnormal or different looking vasculature in the case of optic disc drusen, like in the case of Dr. Shikha had shown. Posterior optic neuropathy is a possibility, but that is only by exclusion after imaging. And as I mentioned, vascular occlusion was nothing suggests vascular occlusion in the fundus. So taking these factors in mind, the fundus, we saw the RNFL defect, but no disc changes, and so we decided to go for neuroimaging. And neuroimaging, what was seen was an extracorneal mass in the right orbit, possibility of meningioma, vascular malformation, or cranial nerve schwannoma, or possibility of helminthic. And you can see the mass was right at the orbital apex and compressing the optic nerve from superiorly, which is causing the superior RNFL defect and corresponding inferior altitudinal hemianopia. As a possibility of helminthic cause was entertained, we gave a course of anti-helminthic treatment with no change in the findings, and hence we referred the patient was referred to a neurosurgeon. And the patient actually had surgery, and surgery confirmed an arteriovenous malformation. So the important lessons from this case that I learned was history is crucial. So the history was a sudden onset versus a long-standing or gradual onset, as in the case of this case, as opposed to in the case of AAON. And fundus finding, as I said, there was no disc changes to whether it was an AAON or glaucoma. You would expect disc changes, which was not there. And if there's a mismatch, always go for neuroimaging. And PION, we can only diagnose by exclusion, where all other causes have been ruled out, then possibly we can say maybe it's a case of PION. Thank you.
Okay, thank you, Dr. Arun. Excellent case presentation and discussion. Did you think of an MR angio when you saw the MRI finding of that hyperdense lesion?
The patient went into the MRI, and the radiologist, as I said, they said the list of possibilities was there. So he said, and also they entertained the possibility of anti-helminthic. So he said, that's why we said we go ahead with the try a course of anti-helminthic treatment. Still no response. And then actually when we refer to the neurosurgeon, they actually have done an MR angiogram. But again, they were not 100% sure. And only it was from the biopsy that the diagnosis was confirmed.
Oh, they couldn't confirm it with the angio before opening it.
They were not sure.
In an extremely rare case, I don't think such cases, rarely you come across such lesions. Yeah.
Dr. Arun, do you know that what sort of an angiogram was done? Is it a catheter angiogram or is an angiogram with an MRI, like an MRA? Which was the type of angiogram which they use? Because in some subtle artery malformation, aneurysms and all, there is a very good chance of missing these tiny ones, so that can be picked up only with the DSA, the so-called catheter angiogram. Do you have any information about that?
I've got the reports. I think they've done a catheter angiogram. It was done at Aster. Yeah, they've done a catheter angiogram, and the possibility was there, but again the radiologists could not comment 100%, and so they went ahead with the surgery. Yeah.
So
usually, before they go inside, they always go for a DSA in these difficult cases. Yeah. Digital subtraction angiography, MR angio, CT angio, you might not get it. So if they are suspicious, always confirmation with catheter angio. That is the gold standard for such small lesions.
Yes.
Extraordinary.
Dr. Karthika, Dr. Lakshmi, can you unshare your screen, please?
Dr. Ambika?
Can I ask one question, sir? So what was the diagnosis? Very nice case presentation you had done. What was the diagnosis on the imaging and what was the treatment offered for the patient, sir?
So the differential diagnosis from the radiologist was possibly a cranial nerve schwannoma, possibly an AV malformation or a meningioma, and possibly helminthic.
Okay, because it's too bright in its signal for us to call it a helminthic, and the location is also quite posterior towards the apex. So the access for the evaluation by a digital subtraction angiogram or any angiographic studies would have been slightly difficult. So what was the treatment offered? Did they do interventional treatment because it was behaving like a phlebolith or anything which is quite bright and which is partly thrombosed AV malformation? It was very focal. As you showed, it produced a very classical NFL defect without much disc changes. So what was the treatment they had offered?
He actually had an open neurosurgery by the neurosurgeon. Okay. Yeah.
Arun, can I add my bit? Arun, very interesting case, very useful. But my take home was that many of the conditions that you mentioned, like you said, would have all caused sudden loss and non-progressive loss. So the fact that this was progressive would for me have suggested either glaucoma or compression. And many of us assume that just because the vision is 6/6, but as a glaucoma specialist, you know only too well that 6/6 vision with optic nerve damage is very likely. So if at all I have to add, I would say that considering he's very certain that it's been progressing, it's been getting worse. So there's been progressive loss of optic nerve fibers. Of the DDs, which were very correct actually. The only two things that I could see, was a compressive lesion, which might have been entertained in your DD. And of course, you went ahead and did the neuroradiology and the management was perfectly fine. But that's the only bit I have to add, that when it is progressive, you think of not just the onset level, but the fact of the progression as well could have given you a clue. Thank you very much.
And secondly, that striking hypersignal, maybe because of the bleed, that has been there for a long time. AV malformation, cavernous angioma, and didn't have any symptom. So the very fact patient came with blurring of vision, and there was a striking hypersignal shows there was bleed at that time. That is the time these cavernous malformations, cavernous angiomas, AV malformations manifest in the brain with seizure, with a different other thunderclap headache, like that. So I think that signal because of the bleed. Maybe the neurosurgeons may be able to tell us more about what they actually saw when they opened up here.
Francis sir, we are running short of time. Can we move on to the keynote address by Pradeep Sharma sir? Dr. Karthika?
The second keynote is Emergencies in Neuro Ophthalmology by Dr. Pradeep Sharma. He is the ex-professor and head of section of pediatric ophthalmology at Neuro Ophthalmology at RP Center, AIIMS, New Delhi. And he is currently the director of pediatric ophthalmology, strabismus and Neuro Ophthalmology Center of Site, New Delhi. Dr. Pradeep Sharma is the first Asian invited to deliver the NAP lecture at AAPOS, Vancouver in 2016, and he has got the Achievement Award by AAO in 2017. He is visiting faculty in Orbis. He is an international member of AAPOS and International Strabismological Association, and he is president of SPOS SI. He has over 200 scientific articles in national and international journals or chapters in books. The books authored include the Strabismus Simplified and Essentials of Ophthalmology, which we all have studied for our PG exams. Over to you, Dr. Pradeep Sharma, sir.
Thank you for that kind introduction. I would like to, at the outset, thank Dr. Srini, Dr. Thomas, and all the KSOS members for this invitation. I would be talking about some situations when our nerves are on fire. So in neuro-ophthalmology, generally, we have more stayed cases, but sometimes there can be emergencies. They can be life-threatening, they can be sight-threatening. There can be situations which can lead us to preventing some catastrophe, or we have to look for is there a treatable cause or preventable cause for vision and in the other eye. Now, this first case is a 75-year-old female was brought to the ocular emergency. Chief complaints were severe headache, total ophthalmoplegia, and bilateral complete ptosis, left more than the right. Visual acuity was 20/200 in the left eye and 20/100 in the other eye. And both eyes, the pupils were sluggishly reactive. Anterior segment showed severe conjunctival chemosis, and fundus showed both eyes disc edema. As you see, these 9 gaze pictures are indicating there is a severe chemosed eyes in both the eyes. And so the questions are whether it's a bilateral cavernous sinus thrombosis, a bilateral Tolosa Hunt, or is it some metastasis which is causing a problem? Well, the imaging reveals, you can see the dilated superior ophthalmic vein very eminently present. And if you look behind, you'll see the cavernous sinus thrombosis. So such a situation, if you do the imaging in time and refer to the neurosurgeon, it can be life-saving. The second case is a 40-year-old male patient presented with the chief complaints of proptosis, pain, and congestion in the left eye. History revealed a road traffic accident 3 months back, following which there was gradual onset congestion and proptosis. Visual acuity was 20/20 in the right eye, and intraocular pressure was 16 and 34 in the left eye. So we again look at the clinical picture, and you can see there is a very severely chemosed eye in the left eye. There is also a deviation indicating a third nerve palsy. But the telling thing is this: if you see this video, you can see the pulsatile proptosis. Now, when this is there, this is a sure sign of a keratico-cavernous fistula. So this is a CCF and clinical examination revealing this, and the enhanced left cavernous sinus and the SOV confirmed. So this is a case for referral for neurosurgeon. This case 3 is a 56-year-old man presented with acute onset severe headache with neck stiffness. Within few hours, he also developed a left ptosis and diplopia, as you can see in the side picture. When we look into the fundus, there was the pupils showed an RAPD in the left eye. The color vision was showing dyschromatopsia. And on the fields, we had seen that there was a bitemporal hemianopia. And as you can see, there was a third nerve palsy. Fundus examination revealed a mild disc pallor in the left eye. So when the imaging is done in this case, what we get is a macroadenoma, which is because of a pituitary apoplexy. There's a sudden enlargement of size in the pituitary. There's a sudden expansion, and these patients usually will complain of the worst headache of my life. 95% people in the studies shown by of these kind is showing that, Ophthalmoplegia is seen in 78%, sudden vision loss in 60%. So this is a life-threatening problem. It can cause hypopituitarism also. MRI is necessary. Hemorrhage may also be there in the subarachnoid space or in the ventricles. And LP can confirm this aseptic meningitis with RBCs being there, and it may mimic an SAH from aneurysm. So the treatment is steroids, hormone replacement, and of course surgery by the neurosurgeon. Coming to this fourth case, this is a 48-year-old male, acute onset swelling and drooping of the left upper lid following a violent sneezing. Now this is very interesting. History of sinusitis he had for 2 weeks, and he had no history of trauma, no history of surgery. He had a blunt trauma 22 years back. Now, mild proptosis in the left eye, 3 millimeters, swelling of the upper lid area with crepitus on palpation. Now, this is a sign which is important. Severe ptosis, up gaze restriction, visual acuity is 6/6 with correction. The pressure was raised in the left eye, 22 millimeters of mercury. The fundus examination was within normal limits at this stage. But when we did the imaging, the X-rays indeed shown a pneumosinus or pneumoorbit with orbital emphysema, as you can see in the sagittal and the AP pictures. And this was a tension pneumoorbit. Now, left-sided acute orbital emphysema. Now, this is a very important condition to be kept in mind. This is rare, but whenever you get these cases, this could be important to save the vision. And as you can see, there can be stages of 1, 2, and 3, and 4, and it can cause a central retinal artery occlusion even in the 4th stage. So we need to get the patient in the increased IOP phase and prevent the CRAO. What do we look for? Causes would be orbital fractures following blunt trauma. In this case, it was 22 years back. Infection, surgery, tumors, but that violent sneezing caused the disruption of the barrier and caused this problem. So we need to observe them in stage 1 and 2, and decompression orbital can be done, which we did in this case. And in this, a needle-coupled syringe, which has been described by Lindbergh, was used to remove the air, release the air bubbles under this thing. And you can see the pre-op and the post-procedure patient, how much improvement is there in the emphysema and the orbital pressure. Sometimes lateral cantholysis or canthotomy can be done to release the pressure on the orbit. So the take-home message in this case is an orbital emphysema can cause a severe problem, and you need to do a needle decompression and save the eye from CRAO. This case 5 is a 76-year-old male, sudden painless diminution of vision of the right eye for 5 days, and there was history of jaw claudication. Now, this is again a very important history that we should all ask for people who have such problems. A scalp pain on combing, headache and muscle pains for 15 days. Hypertension on medication for last 10 years, and a CKD. Now, when we look into the fundus, we find there's a pale disc edema. Now, in such a situation, whenever we have a suspicion of an ischemic optic neuropathy, as in this case, we always immediately order an ESR and CRP. Now, both of these are supposed to be together pathognomonic by Here. So if these are both raised, we need to immediately start steroids. So then it could be an arthritic anterior ischemic optic neuropathy. So as you know, ischemic optic neuropathies could be AION or a PION. And AION again can be arthritic or non-arthritic. The non-arthritic ones are more common because of hypertension, diabetes, or CAD. But the arthritic ones are the ones which are more acute and which we need to salvage the vision for. So whenever we have these situations, the distinction should be made between AION and NAION. Remember that steroids are going to be sight-saving in arthritic AION, whereas in the non-arthritic ones, it may be controversial. And a study done at RP Center, the work was started by James Matthews of Kerala when he was a senior resident with us. And that was now completed and published by Dr. Rohit as the first author, which showed that steroids have no role of beneficial effect in cases of non-arthritic AION. The only treatment is specific cause for hypertension and diabetes. Low dose aspirin can be given to prevent a similar episode on the other eye. Now, this case 6 is a 48-year-old female patient presented with acute onset right upper lid drooping, limitation of extraocular motility, except for abduction and torsion. There was severe headache. Systemic uncontrolled diabetes was there for the last 10 years and hypertension for 10 years. Now, we see that this is the 9 gaze showing a typical right third nerve palsy. Exotropia, hypotropia, and isochoria is also there. So it's involving the pupil. And we did the relevant investigations to confirm these things. What we find in the MRI is that there is increase in swelling. And when we did the KOH mount from the nasal mucosa, we found there was a broad non-septate hyphae suggestive of mucormycosis. Now, mucormycosis has become much more relevant after the COVID era, but even prior to that, it used to trouble us. And this is the case in which an IV antifungals have to be given for a prolonged time to take care of this. Case 7 is showing you a 29-year-old obese female with a raised BMI of 34, diplopia, increasing headaches, and history of visual obscuration. Now, this is an important history we should ask in such ladies. Usually they are females, but males also could be affected. And a throbbing bifrontal headache or heaviness itself is felt by them. So this disc edema is seen on the fundus. All of you know this is a papilledema. Bilateral disc edema is there. And if you see the imaging, it can show you the bulging of the optic nerve in the globe. But we did a study and using the OCT on the optic nerve head, using the macular cube on the optic nerve head. And this is what you get in normal cases. The line of the Brooks membrane and RPE is shown here. The angle formed is minus 5.32. Whereas in a case in which there is a papilledema, you'll see that this angle is in positive 15 or something. And this is in papillitis, you'll see it is not much change. It is. So intervention in such cases is, of course, you may do a CSF tap by the help of the neurologist. It may be a fulminant IIH. In this case, it was, which was causing very severe reduction in vision. So the optic nerve sheath fenestration was done. But in other cases, we may do a weight reduction and start acetazolamide treatment, and it helps. This case 8 is a young girl who was aspirant medical student in Kota, and she was presenting as headache and diminution of vision. There, the local ophthalmologist treated it as a neuroretinitis, but she was not getting relief. So she came to our center, and we just got the blood pressure check. She was a young hypertensive, having 200 by 120, and this was the basic problem. It was basically a hypertensive optic neuropathy. And this last case is suggesting another thing that we need to always look for, the movement. This child is having an asymmetric nystagmus. The right eye nystagmus is much more. And if you have this, you should think of imaging in these cases. The craniopharyngioma was seen in this case, again, which was referred to the neurosurgeon in time. So I would like to come back to the take-home messages. Important points in history are symptoms: loss of vision, diplopia, eye pain or headache; onset, the duration, frequency, progression, and associated features, especially like jaw claudication; past history or present history, diabetes or immunosuppression. In ocular examination, look for visual acuity, distance and near both. The near vision, particularly in third nerve, for example, would be affecting. Color vision should be looked for. Pupil size, RAPD is always important to be seen in these cases. Visual fields. Now, this is something which sometimes we miss. And even if you don't order a fields, at least do a confrontation fields in your clinic itself. An amsler and a finger confrontation can be done. Ptosis evaluation can be done for more details, and deviations in all 9 bases. Examination, look for the disc, the sharpness of the margin, the color, the cup disc ratio, obliteration of the cup, disc edema with obscuration of vessels at margin of disc. Absence of spontaneous venous pulsation is a sign which may not be seen in all cases of papilledema, but that should be looked for. Retinal hemorrhages, arterial attenuation, venous dilatation, and retinal emboli. So if there is a history with vision loss, one should differentiate whether it is a neurological cause or an ophthalmological cause. If it improves with pinhole, it may be a refractive error. If there is metamorphopsia, think of maculopathy. If there is an RAPD, defective color vision and contrast sensitivity, think of optic nerve problems. If there is a monocular versus binocular lesion anterior or posterior to the chiasma, should be differentiated. Fields, horizontal versus vertical, can help you in diagnosing whether it's an altitudinal or a pre-chiasmatic or a post-chiasmatic defect. So this is what I would like to end my talk. Thank you for a very patient listening. I would like to thank Dr. Shamir, again, who might be listening, who had arranged some of these cases. Thank you, Dr. Shamir, and thank you all for a patient listening.
Thank you very much, sir. I'm waiting for Francis, sir.
It was an excellent talk again. Yeah, thank you very much. I think 2 important points all the delegates have to remember. One is blood pressure. Whatever be the symptom, headache, blurring of vision, maculopathy, retinopathy. I too have seen patients, without getting a blood pressure checked, and you diagnose papilledema, you send for MRI. Second is this ESR CRP. That also is very important, especially above 60, 70. I have seen patients of migraine with allodynia, where their scalp will be very tender, whichever area they get the headache, and even combing, everything will be painful for them. So in a young patient, it is migraine, maybe sinusitis also they can get, but in elderly, it is always giant cell to be ruled out. Thank you, sir. Thank you very much.
Thank you.
Dr. Sharma, sir, I have a small question. Is how important and significant are the TAB, the temporal artery biopsy? Even if you have a negative temporal artery biopsy on either side, if the clinical picture is suggestive of GCA, I think it is proper for us to initiate the patient on treatment for GCA.
That's right, Dr. Raju. I think we rarely do temporal artery biopsy. Maybe 1 in 100 cases when we are having a doubt, but otherwise it is not really indicated. Most of our cases are diagnosed clinically. The most important, I think, test is ESR and CRP. So whenever both of them are raised, we always start them on pulse steroid for at least 1 day, and then continue on oral steroids, and then monitor them on the basis of ESR. Temporal artery biopsy, as you have rightly said, may be negative in many cases because there are areas of skip. So if at all people have done, they have done ultrasound guided biopsy. So they do an ultrasound over it and then do a biopsy. But I would say, I mean, in our clinical setup, it may not be really worth and it may not be feasible. It may be more for an academic interest, and we would start the treatment on without the biopsy.
Sir, another thing is that about the treatment part of it with the steroids. Many of these patients may be very diabetic. They may not be able to tolerate the steroids systemically. So in that case, and also we have to continue the steroid therapy for a very longer period of time, maybe 6 months, 1 year, etc.
Right.
In such cases, what is the role of immunomodulatory drugs in the management of, what is your experience?
Generally, what we have done is these patients, some of them may be diabetic. Most of these arthritic are may not have diabetes, and they may be young also at times. So arthritic doesn't really mean that it should be old diabetics only. But if they are having a diabetes, they may have to be admitted for their diabetes getting worse. And this we have to counsel them. And if need be, because steroid is not only sight saving, but maybe life saving for them, we need to admit them, control their diabetes, and then still give the steroids. Initial phases, we do give only steroids. For the later part, after 2 or 3 months, when we have to continue steroids, we may use steroid-sparing drugs, like immunosuppressants.
And I think recently, MRI, high-resolution MRI signs have been documented in giant cell arthritis. The inflammatory vessel walls can be seen with contrast. I remember reading, one study on that. Yeah. Very recent, maybe last 3-4 years.
Dr. Sharma, thank you. It was very useful. But can I just add that for the benefit of everybody,
Yes,
that steroids in arthritic AION are not to get back the vision in that eye, but to prevent vision loss in the other eye. And far more important, other comorbidities like CVA, MI, damage to the kidney, because it's a generalized arthritis.
Right.
So steroids are continued for a long time because of the morbidity associated. Not usually the vision loss in that eye is lost forever. It's the other eye that we're trying to.
But fortunately, sometimes we have recovered the vision in that eye also if we have started in time. I mean, this is something interesting, that even that eye, the vision has recovered. But you're right, it is more for saving the other eye and the life.
Do we have time for a comment?
Yes, please.
Okay, see, in giant cell arthritis, you don't need always a positive tab. I agree. But there are conditions, 3 to 5%, we may end up having normal ESR and CRP also, because that is also being described. And in fact, we had a recent case where we had a relatively high suspicion clinical index of giant cell arteritis in a 70+ male, but had a normal ESR and CRP on repeated evaluation. But all he had was a headache with an inflamed temporal artery. So without any clinical positivity, we went ahead with the temporal artery biopsy, and we were shocked to see that he was positive for a giant cell arteritis, and we started him on steroids. Number 2 is there was a take on whether to give a steroid for a long run or not. We have a steroid sparing group of drugs also available. Start involving a rheumatologist in the picture from the beginning, because they may be a person who will be apt to continue this in the long run. We have a patient who is on tocilizumab. Almost we have put the guy on 6 cycles of tocilizumab with a low cover of steroids, and he in fact had bilateral presentation asymmetric with giant cell arteritis. As Dr. Sharma had said, he did not recover in one eye. He had some amount of recovery in the slightly milder involved eye. So watch for these signs. And there are steroid sparing drugs also as an option of treatment, apart from the conventional modalities. Thank you.
Thank you, Dr. Ambika. As usual, great presentation by Pradeep Sharma, sir. We will just quickly move on to the second case presentation of this session by Dr. Sujitra.
Dr. Sujitra is an associate professor in AIMS, that is on the Institute of Medical Sciences, and she is the current treasurer of COC. Over to you, Dr. Sujitra, for the case presentation.
Am I audible?
Yes, Sujitra, you can go ahead.
Can I start?
Yeah.
Thank you, Dr. Arun, for including me in this great session. I start with my case. A 34-year-old lady presented with complaints of difficulty in locating small moving object. So she had one episode of severe headache, following which she experienced this visual disturbance. She was a known case of migraine and was taking analgesic, and no other positive history we could elicit. On systemic examination, all systems were within normal limit. On examination, visual acuity was 6/6 and near vision also 6/6 with near vision add, and color vision was normal, extraocular movements were normal, and pupil examination, ocular movements also within normal limit. Fundus examination also was normal, disc, vessels, macula were normal. So then we did fields, so it showed central scotoma. So it was reproducible, and on repeated visual examination, visual field examination also showed the same field defect. So, but she had vision 6/6 and near vision 6/6, and color vision also was normal. So we were wondering about the diagnosis, and initially we thought, whether it is malingering or so repeated. We did fields repeatedly, and it was reproducible and reliable. Then we did 10-2. In that, the central 5-degree was spared. So with that, she was reading 6/6 and N6. So she was finding difficulty in locating the small moving object. When during shopping or when somebody is giving something, it takes some time to locate the other person's hand or the object. That was her difficulty. So this 10-2 also was repeatable and reproducible. Then VEP showed delayed latency and amplitude was also reduced. MRI and MRA was done. That also was normal. Central scotoma, that is bilateral and sparing the central 5 degrees. So what's the diagnosis? Probably ischemia of terminal branch of PCA bilateral. Maybe she gave history of severe headache. At that time, she might have had some ischemic attack, which caused this field effect. And now we are following this patient for about 10 years. It is remaining the same. No improvement or no, it's not worsening. So it's open for discussion.
So Jitra, recently I had occasion to read about this, and there's something called the acute macular neuroretinopathy, which perfectly matches what you are describing. I'm afraid that offhand I cannot authoritatively in front of the group tell you everything, but whatever I remember of acute macular neuroretinopathy is identical. We are not people, and as far as I remember, it's the OCT that is diagnostic. So again, I've forgotten what the OCT would show. There's something wrong with the inner retinal layers. So I would advise, I'm sorry, I can't be more specific, that people read up about this, the acute macular neuroretinopathy. Okay, thank you. That's all I have to share.
Yeah, I would also, I have similar thoughts. While you have done a wonderful workup, Dr. Sujitra, I would also like to look at the retinal processes, because there are forms of, as Dr. Padmaja also mentioned, there are forms of white dot syndromes, which can be self-limiting, which can cause these kind of scotomas, and they can go away. And a lot of times you may not find a very well-defined retinal lesion. So I would, apart from VEP, I would say if you look at the ERG and multifocal ERG, probably you would have some indication as to what's going on.
Maybe add an OCT also along with it.
Absolutely.
OCT will give you the clue of loss of the which layers we are dealing with. And you have mentioned that you have followed the patient over 10 years.
10 years.
Even by 10 years, you did not see any fundus findings, a retinal change or an optic disc change?
No, madam. Now she is diabetic. So initially, I think I saw her in 2009. At that time, she was not a diabetic. Now, after 5 years, she is diabetic. Mild diabetic retinopathy changes are there. That is mild NPDR. Then initially, at first time when we saw her, at that time we tried giving vitamin B12 and we gave one course of steroid also. And there was no improvement. So we thought must be a terminal branch occlusion due to ischemia.
Yeah, even if we think in terms of a macular pathology, in down the line, we can visibly see structural changes on an OCT.
Yes, madam.
So
now
it can,
yes, and
yeah,
sorry, we
maybe
didn't include that OCT picture. Now there is the GCC loss in the macula, but the field is same, and both 30-2 and 10-2 field is remaining same. No change.
And in the imaging, was it a contrast enhanced diffusion
Yes,
sequences?
It was
You
contrast enhanced, and MRA also we did. MR angiogram also we did. We have in America we have very good radiology department. In and out we worked up. Then since she is stable, then we are following up like that. Now she is diabetic and started diabetic retinopathy, mild diabetic retinopathy.
I remember another small fact, Sujitra, for
There
what
is
it's
one
worth.
patient is a
Possibly.
migrainer. Patient is a migrainer, and this visual loss was when she had that severe migraine attack.
Yes, that's what she is.
There is one condition known as RCVS, reversible cerebral vasoconstriction syndrome, which are more in migraineurs. They get severe thunderclap headache.
Was it reversible?
It is known as reversible, but there are infarcts which have been documented to continue for a long time, like other infarcts. So I think maybe, as you said, bilateral PCS spasm, maybe some of those terminal branches which we are not able to pick up in an MRA. Maybe DSA might pick up, digital subtraction angio or catheter angio. But then, there is a risk in that. So I think better to continue like this. Now, 10 years, I think it is unlikely it is a, outer retinal problem. You must get some retinal changes by 10 years. Yeah.
Thank you. Can you stop sharing?
Okay, I think this session over, Arun?
Yeah, concluding remarks, sir. Concluding remarks.
Okay.
Yeah.
I think it was an excellent session with great cases, simplified with a lot of images and videos. And I hope it was beneficial for everyone in their day-to-day neuro-ophthalmic practice. I thank Dr. Shikha, Professor Pradeep Sharma, and Dr. Arun and Dr. Sujitra for their very excellent case presentations. I think it was a very wonderful session. Thank you very much. Thanks, everybody.
Thank you, sir. Thank you, sir. Karthikeyan? We'll now go to the next session. Session 2.
We'll go into the next session, that is session 2, which will be chaired by Dr. N.S.D. Raju, sir. He is a pioneer cataract and phacosurgeon, and he is the former president of AIOS. He is a keen neuro-ophthalmologist too. He is the director of N.S.D. Raju's Eye Hospital and Research Center. And the panelists include Dr. Ambika S., Dr. M.V. Francis, and Dr. Smita Bassi. The keynote will be done by Dr. Rashmin Gandhi. It will be on decoding the pupil. He is the managing director for Sight Worldwide, consultant director, Neuro Ophthalmology, Center for Sight, Hyderabad. He is the vice president of Indian Neuro Ophthalmological Society, and he is an adjunct professor in the University of Hyderabad. Dr. Rashmin Gandhi's areas of interest include development of new technologies in ophthalmology, education, community outreach programs, and his honors are many, including the Achievement Award from Asia Pacific Ophthalmology in 2019 at Bangkok. He has got a special gold medal by Intraocular Implant and Refractive Society of India in 2015. He has won the award for academic excellence by the then Honorable Chief Minister of Gujarat, Sri Narendra Modi. He has got the C.V. Anantha Memorial Award from His Excellency Sri Rosaya, the Governor of Tamil Nadu. He has got the Young Super Achiever Award of Chennai, and he was the Best Associate Consultant of Shankar Nethralaya in 2002. There are many more. Over to you, Dr. Rashmin Gandhi.
Thank you so much. Thank you. I would like to thank Dr. Thomas, all my friends at KSOS for this honor. My talk is on decoding the pupil, and I would like to highlight the importance of examining the pupil by sharing few cases. Decoding the pupil, our role would be in IOPD, and there are two most important pathologies that you would like to look at. One is the difference in the size of the pupil, and second, pupillary reaction. And second, decoding the pupil would be when we are called to examine a patient who is in a neurology ward or in ICU. So let's look at anisocoria. And this is an hypothetical case. If you see a patient where there is a difference in size of the pupil, in a normal room light illumination, let's say your right eye pupil size is 6 millimeters and the left eye pupil size is 3 millimeters. What is the next question? The next question is, what happens to this difference in the size of the pupil when you examine this patient in a brightly lit environment versus in a dim environment, in a mesopic versus a scotopic condition? And for discussion's sake, let's see what happens to the pupil here is that the anisocoria becomes dark, more in dark. So now there are three possibilities, right? When you check anisocoria in bright environment, dark environment, and it can be that anisocoria becomes worse in bright, anisocoria can become worse in dark, or it can remain the same. If it remains the same, it is much more likely to be physiological. If it becomes more in dark, that means sympathetic system, which is supposed to dilate the pupil in dark, is at fault. This patient might be having Horner syndrome. If anisocoria becomes worse in bright light, that means the difference in the size of pupil becomes worse in bright light. You know that maybe there is a problem with the parasympathetic system. And these are the pictures to highlight. This is the patient you see. The left pupil is smaller and the right pupil is larger. How do you check for difference in bright versus dim light? And this is the picture which was shared with me by Dr. Devendra Venkatramani. And you see here the patient has anisocoria, which is not very clear here. You see what happens in dim versus bright. You see in dim environment, this right pupil is dilated, the left pupil is not dilated. In a bright environment, the anisocoria is much less. So this is an example of anisocoria becoming worse in dim environment. This patient having Horner syndrome, as was highlighted by Dr. Shikha, Bassi, Talwar also talk, that when anisocoria becomes worse in dim environment, you're looking at Horner syndrome. If patient also complains of pain, acute onset Horner syndrome with pain is a medical emergency. These are some of the causes of patients with Horner syndrome, but acute Horner syndrome with pain, patient might be having dissecting carotid aneurysm. Why it is important for us to diagnose this? Because this patient, when there is a dissection of larger artery, it can throw up an embolus. Patient can end up with myocardial infarction, stroke, or embolus getting lodged anywhere in the system. And that's the reason why the take-home message from first case is Horner syndrome, anisocoria becomes worse in a dim environment. Acute onset Horner syndrome with pain and emergency. Always ask for neuroimaging, appropriate neuroimaging, which should involve the MR angiography of the neck as well. There have been a lot of pharmacological tests which has been described in the past to diagnose or confirm or to localize Horner syndrome. A lot of these agents like cocaine and hydroxyamphetamine are not available easily to ophthalmic practitioner. There have been reports of practitioners using phenylephrine 1%, diluted phenylephrine, to diagnose and localize Horner syndrome. I generally don't use them. This is case number 2. We are looking at anisocoria even now. And let's see what happens here. So the patient has ptosis, and I will be checking ocular motility with the torchlight, and you'll find here that the right pupil is larger than the left pupil. You'll also find that patient has ocular motility issue where the elevation is limited. So here is a patient with ptosis, limited of ocular motility, and a larger pupil on the same side. So you are probably dealing, again, it's an anisocoria. This anisocoria will become worse in a bright light. You're dealing with a third nerve palsy with pupil involvement. Now, why this is important? Because third nerve pupil involvement in the setting of third nerve palsy tells you that you are dealing with compressive lesion of the third nerve. One of the common compressive lesion of the third nerve is posterior communicating artery aneurysm. Why it is important? Again, it's an emergency. Why it is important? Because this posterior communicating artery aneurysm can rupture, leading to either death or a permanent neurological disability. This is a rule of pupil which is being published by Dr. Andrew Lee, which tells you that if patient has an incomplete third nerve palsy, you still should go ahead and investigate that patient, and investigation should include MRA or even DSA if the index of suspicion is high. The only place where you will feel that you're probably not dealing with a compressive lesion of third nerve is where there is a complete ophthalmoplegia and there is no involvement of pupil. So again, highlighting big is not always better. This patient had ocular motility problem which looked like INO but had a pupil involvement. Patient had a compressive lesion. This is case number 3. We are still staying with anisocoria. And I hope you're able to see here, patient has a difference in the size of pupil where left pupil is larger than the right pupil. I'll be checking it in bright light versus dim light. You see dim light, the anisocoria is lesser, while in the bright light, the anisocoria was much more. So now we are dealing in this patient with anisocoria which is worse in bright light. The difference in size of pupil increased when the ambient illumination was more. So we are dealing with a parasympathetic system problem. You check for ocular motility. Ocular motility is fine. That means you know that you're not dealing with third nerve palsy in all probability. What is the next step? You look at a reading. Let the patient read for a while. You might be dealing with one of the differentials would be AD's tonic pupil. It is called tonic pupil because the constriction and dilatation is slow. So these patients, you should ask them to read for around 30 to 45 seconds. If you're dealing with AD's pupil, you'll find that the larger pupil will slowly constrict. And when you ask the patient to look straight ahead after converging, you'll find that the dilatation also is equally slow. What is the confirmation of diagnosis in this patient? You would apply a diluted pilocarpine, generally 8 to 16 times dilution of pilocarpine. You will find that left pupil, which was larger, now has constricted. Please remember that when you do a diluted pilocarpine test, you will instill diluted pilocarpine in both the eyes because the normal eye acts as a control. We had this patient which we had seen when in Chennai, where patient had bilaterally dilated pupils. There was no change in dilatation, this difference in size of pupil in bright or dim environment. And after thorough history taking and investigation, we didn't find anything. A further detailed history revealed that this patient was in the police and he was getting transferred somewhere which he wanted to avoid. And he had actually, after going through the internet search, had applied the dilatation drops in both the eyes before consultation to make sure that we give him unfit certificate. So that's something which you should keep in mind. Another important area where you should look at the pupil is this. My video is not playing, but this patient also can have light near dissociation, dorsal midbrain syndrome. Patient can have light near dissociation, vertical case palsy, and can have convergence, retraction, nystagmus. So anisocoria, to conclude, in anisocoria, third nerve palsy, trauma, pharmacological, Horner syndrome, AD's pupil, or even a local problem like post-cataract surgery or uveitis can lead to anisocoria. A word about RAPD. Make sure that RAPD, relative afferent pupillary defect, is checked in a dim environment where patient is looking at a far object and not at your face, and to make sure that each pupil is illuminated at the same angle and with equal illumination. Because RAPD is relative. You're looking at one pupil versus the other pupil, or one visual pathway versus the other pathway. A lot of times we find in the report, just a larger pupil is written as RAPD. RAPD is a defect of afferent pathway and is denoted by performing swinging flashlight test. Just a larger pupil on one side does not denote RAPD. Documentation is by using neutral density filter. What is the importance of RAPD? Apart from making sure that all unilateral optic nerve diseases would have RAPD, and it's an objective test of unilateral optic nerve disease. This was a study which was published by our friends Ronnie George, Nikhil Chaudhary, and glaucoma group from Shankar Nethralaya, where they looked at 6 cases which were initially diagnosed as having glaucoma, but they turned out to be a neurological case. And important point number 2, all 6 cases, the clinician had failed to document morphology of pupil. So pupil becomes very important in patients like this, like a normal tension glaucoma, because as I said, unilateral optic nerve disease, because of neurological disease, would always demonstrate pupil. In glaucoma, to demonstrate RAPD, you need to have a difference of cup size of more than 0.2. Conclude pupil in neurological ward, and this is something I would like to thank Dr. Raju, because he called me up in the night to discuss, saying you should be covering these important topics when you're talking about decoding the pupil. He wanted me to touch upon dynamic oval pupil or Hutchinson's pupil. As we know, Hutchinson's pupil is seen in somebody who has a head trauma or a cerebral edema. And what happens there is that there can be a constriction of, let's say, if patient has a tumor on the right side, there can be constriction of the pupil initially because of irritation of third nerve. Then that pupil will start dilating, and the contralateral pupil can constrict because of irritation of contralateral oculomotor nerve. And in the end, both pupils will dilate, and that is a very grave prognosis. Dynamic oval pupil is one of the earliest stages of this process. So if you are following up a patient in neurology ward, and if you start seeing a patient which has an oval large pupil, which is dynamic, which can become smaller initially and then becomes dynamic oval, you know that patient is going into a brainstem herniation. And if any intervention which is planned from neurosurgical ward, then that has to be planned immediately. So neurological ward, you're looking at mainly dilated pupil. It can be dynamic oval pupil or it can be Hutchinson's pupil. This, I would like to thank Dr. Thomas and KSOS once again for this opportunity. Thank you so much.
Thank you very much, Dr. Rashmin. May I request NST Raju sir for your comments, sir. NST Raju sir. So you're on mute, sir.
Okay. Dr. Rashmin, that was a very outstanding type of presentation that you have made, highlighting all the important clinical aspects of examining the anisocoria and how to differentiate the small people and the large people, how to diagnose and differentiate the Horner syndrome and the Addis people. And also thank you for including the oval people, which I think is clinically very important. That is a very ominous sign. It tells that the patient is having a brainstem problem. You go in the midbrain, in the rostral midbrain, that is in the process of evolution. Unless and until you diagnose that and send the patient to a neurosurgeon, the patient is in problem. So thank you for including that. That is one take-home message. And the other thing is about the parasympathetic paralysis. The Addis paralysis, it is an innocuous situation usually. Sometimes it is associated with an areflexia. Does that have the Addis, what is called Addis-Holmes pupil? No. Does it have any special significance, Dr. Rashmin?
No, I don't think Addis pupil lead to any other associated grave neurological disease. It can be associated with the hyporeflexia, as you mentioned. Another important point is in 20%, it can be bilateral, and Addis pupil over a period of time, over a period of few years, though both pupils will become smaller. So it can be self-limiting over a period of time.
You also mentioned about the injury causing the internal carotid artery dissecting aneurysms. So these are usually the vehicular accidents, and also this roller coaster. I think we also have the roller coasters in India also, because of the whiplash effect, it stretches your neck so that it puts strain on the internal carotid artery and the internal lamina that ruptures, and the blood dissects into that space and causes the thing. So these patients, in addition to the Horner syndrome, they also complain of neck pain and facial pain. So that is an important aspect which in the history you will have to elicit, because this is an emergent nature clinical situation, and we should immediately refer the patient to the neurosurgeon. Am I correct, Dr. Rashmin?
Yes, sir. Absolutely. Thank God.
One point, Dr. Rashmin. In US also, 1/3 of these aneurysm ruptures are missed in US emergencies. Subarachnoid hemorrhage, according to the latest headache classification. And most of the diagnosis as migraine, acute migraine. And second, the investigation also is important. Generally in the periphery, they all go for CT scan. And if you only go for the first day only, you can get a 98% sensitivity. If you go for third day, it can become 90% or less. So ideally, one must go for lumbar puncture, which is not done in many centers. Yeah. So these two are very important. Yeah, missing subarachnoid hemorrhage and not ordering for the right investigation.
Thank you, sir. Can go to the case presentation.
Next case presentation, that is case number 3, and panel discussion will be done by Dr. Revati Ramesh. She's a senior consultant neuro-ophthalmologist at Dr. Tony Eye Hospital, Alwa. Over to you, Dr. Revati.
Before Dr. Revati starts, may I just thank Dr. Rashmin. He has to leave to catch a flight. Thank you very much for your excellent talk. Thank you.
Thank you so much. Thank you, sir.
Okay, Rashmin. Thank you so much.
I would like to first thank Dr. Arun Thomas and COC for giving me this opportunity. I share a case, maybe to get the. Are you able to see my screen?
Yes, Revati. Go ahead.
Yeah. So it's a case of a young girl. Sorry, I'm having some trouble. Yes. Of a 17-year-old female patient who complained of bulging of the right eye of 1 year duration. There was no other relevant ocular, medical, personal, or family history.
Slideshow.
Yeah.
Just go to slideshow, Revati, in the top slideshow.
Yeah. I thought I was in slideshow. Is that okay?
No.
Are you seeing my slideshow?
No, not yet. I think you have to redo that again.
You can just click on the next slide. Just click on the next slide one by one.
On my screen, it is on slideshow.
Okay. Then you have to just go out and come back again. Just
please unshare and reshare.
Don't exit. Just stop slide sharing and redo.
Okay.
And you can speak a bit louder as well. Yeah.
Okay.
Nice. Yeah.
Are you seeing slide sharing now?
You see the first slide now. Just click on.
Yeah. Is that the slideshow?
Not it. So just click on the next slide. Click on slide 2.
1 second. Yes.
Okay. You can go like that.
I think I'll go like that.
Yeah.
So 17-year-old female patient is complaining of bulging of the right eye of 1 year duration. There's no other relevant ocular, medical, personal, or family history. On examination, her I think there's a slide missing. Her best corrected visual acuity in the right eye was 6.9 and 6. Left eye was 6.6 and 6. And on examination, the right eye, there was an obvious proptosis. Exophthalmometer reading also showed presence of proptosis. Intraocular pressures were, however, normal. Motility examination revealed full motility in both eyes, and the eyes were both orthophoric. Field examination showed in the right eye grossly blurred disc margins. The vessels were obscured. The disc was hyperemic. There were ILM folds in the macula. Left eye, the fundus was normal. Field examination revealed superior arcuate in the right eye. The left eye, the field was normal. So investigations, blood investigations we did for good defect. Thyroid function tests were also normal. Then we immediately sent her for a brain MRI brain and orbit contrast enhanced, and this showed a well-defined oval-shaped lesion rising from the intraorbital part of the optic nerve with the long axis of the lesion seen along the course of the right optic lesion, right optic nerve. The lesion was iso to hyperintense in T2 weighted images, and the likely diagnosis was a optic nerve glioma. Because of this very typical picture in the MRI, initially the radiologist and us, we thought that it was there was no doubt about the diagnosis. She was actually seen by a tumor board who also concurred with the diagnosis. And so since the visual acuity was very good in this patient, she was selected for chemotherapy and followed. She was started on vincristine and carboplatin. And after 7 chemo cycles, the patient developed foot drop. And vincristine was stopped. Actually, in the treatment of any condition with vincristine, a neurological side effect is said to be a treatment stopping point. So they stopped vincristine and continued her on carboplatin. She has now had over 16 cycles of medication. The clinical picture, that is the proptosis, the visual acuity, fields have all remained status quo. I have presented this case to ask the panel as to whether any other therapies are available at the moment, vincristine and carboplatin being the gold standard. Do we have any other options on a case like this? Can I stop sharing my screen?
I think that final decision will have to be taken by the oncologist who is treating that patient. And there is any possibility of removing that tumor from the optic nerve. I think it is fraught with dangers, and you have to cut the optic nerve, and the eyesight will be lost completely. But it may be possible there might be alternative drugs available to continue the chemotherapy, even in the absence of vincristine. I think the best option will be decided by the oncologist rather than the ophthalmologist.
Madam, do you have any coronal sections of the MRI?
Unfortunately, no. The patient who did not, she had gone to a center where they had just given the report to the patient, and the coronal sections were not available to us.
That's a very nice case, Dr. Revati. And as you have rightly planned, chemo will be the key for the treatment for a OPG. But the only thing is the vision maintaining for the patient, or is there any progressive drop in the vision or
No, so
visual
far
fields?
We've followed her up now for 2 years. The vision has remained the same, and so has the field.
Okay, so if there is a visual stability, probably after these cycles, because usually they give a survival-free, a chemo-free period to see for the response to the treatment. And as you said, you have already developed some toxicity to the drugs existing. And being a young girl, we have to think about the secondary consecutive effects of these chemo, because these patients developing leukemia is also on the higher side. Secondary leukemia post-chemotherapy is also possible. So if the visual stability has achieved and her proptosis is stable, there is no further worsening, it's ideal to watch the patient over a period of time, keep her in a close follow-up, unless there is a further drop in vision. Yes, there are some second line like procarbazine and limousin, which are being tried by our oncology team when there is an indication, because we had a couple of patients with ototoxicity and one patient developed a leukemia during the treatment. So we had to stop the treatment just like what you have gone through. So we gave a treatment pre-interval and we watched these patients, and most of them did sustain their vision. In order to get a visual recovery, probably we can also avoid the secondary chemotoxic effects of these drugs rather than escalating the treatment. This is what is my opinion. Over to you, the panel.
I think that was the neurotoxicity induced by vincristine. It's notorious for vincristine to cause neurotoxicity.
Peripheral, neuropathy. Dr. Virender, do you want to add anything?
Thanks, Dr. Arun. I fully agree with what Dr. Ambika has said. I think we are not going to get a complete resolution of the lesion, but the idea is to prevent any further progression. So given that, if we have achieved that, possibly close observation with close monitoring of the visual fields and also documenting the OCT changes every 6 months would be ideal. No further treatment unless until the lesion is progressing. Given a very young patient, radiotherapy would not be the preferred way to be added. So if the lesion is confined, to one orbit, it's not neurofibromatosis, and it's stable. Possibly that would be close observation would be the best.
And one more thing on repeat imaging, if you still have some residual lesion, because of late proton therapy is also another option for these patients to reduce the amount of radiotoxicity and potential chemotoxic side effects. You could consider that and take an opinion from your radiation oncologist.
Thank you. Thank you very much, Dr. Virender and Dr. Ambika. Raju sir, shall we go to the case presentation?
Yeah, we can go to the next case.
Next talk by Dr. Virender. Yeah, talk by Dr. Virender.
The next keynote talk is on recent advances in optic neuritis. The speaker is Dr. Virender Sachdeva, consultant ophthalmologist, Department of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology at L.V. Prasad Institute, Visakhapatnam.
Thank you very much, Dr. Arun.
Dr. Sachdeva's areas of interest include optic neuritis, IIH, neuroimaging, myasthenia, and supranuclear disorders. He has over 83 publications in peer-reviewed international journals, 20 book chapters, including textbook chapters in neuro-ophthalmology. He's an expert panel for neuro-ophthalmology papers for AIOS and reviewer for many journals, including AJO, BJO, BMC Ophthalmology, IJO, etc., to name the few. Over to you, sir.
Thank you very much for the kind introduction. And thank you, Dr. Arun, for the kind opportunity. I thank Kerala Ophthalmological Society for giving me the opportunity to interact with you all. Can I share my screen? Thank you. So, I hope my slides are visible and I am audible.
Yes, Dr. Virender. Yeah.
Thank you. So, we were discussing, Dr. Arun and myself were discussing that how to go about the talk, and we were thinking that it would be best that we can keep it like what is the current understanding of management of optic neuritis in 2022. I will be trying to cover the talk in the following sections, like giving a current insights into the etiology. What do we know today about the etiology? What should be the recommended workup of a given patient with optic neuritis? What are the guidelines for treatment and workup of the patient, current understanding in pediatric optic neuritis, and a little bit about optic neuritis status post COVID-19 infection or vaccination. So moving ahead, we know that optic neuritis is usually secondary to demyelination, and it can occur as a clinically isolated syndrome, not as part of a systemic demyelination disorder or as a part of a neuroinflammatory syndrome that affects the central nervous system. Among them, the most common causes which are well established today are multiple sclerosis, acute disseminated encephalomyelitis or ADEM, neuromyelitis optica, and MOG-associated demyelinating disorders. We should not forget that in India today, a lot of patients might still have para-infectious and post-vaccination optic neuritis. So do keep that also in the mind in the spectrum. To highlight what the scenario might look like, I'll take very short, brief examples. I'm not going into all details, but telling only the positive findings in the interest of time. So first case is of a 19-year-old female who presented to us with sudden onset blurred vision in right eye for about a week. And then there was a history of viral fever 20 days prior. There was pain on eye movements, but no other neurological complaints. Visual acuity was markedly depressed to counting fingers in right eye and 20/20 in the left eye. There was right eye grade 3 RAPD and rest examination was normal. Looking at the fundus of the patient, we can see that both discs are normal and the rest of the retina was also normal. So given this, we took a diagnosis of right eye optic neuritis, possibly post-infectious given the history of the viral fever, and we obtained an MRI of the brain and orbits. These are the orbital sections. We can see that the right optic nerve is bulkier, thickened, and we can see a flare sequence showing a hyperintense lesion in the right orbit. In the post-contrast image, we can see that there is an increase in the brightness of this, and it's matching the brightness that we see in the muscles, suggesting that there is a uniform post-contrast enhancement. It's an active lesion affecting the optic nerve, suggestive of a demyelinating disorder. Rest of the brain MRI was normal. and the patient was treated with injection IV methylprednisolone 1 gram for 5 days. 2 weeks post-treatment, the patient had good recovery of visual acuity in both eyes. Color vision started improving, and there was only grade 1 RAPD in the right eye. Over a period of time, the patient has maintained a normal neurological examination, no recurrences, and no other neurological complaints over the next few years. So this confirms that the patient had isolated demyelinating optic neuritis, which is possibly post-infections. Moving quickly to another example, this is a 25-year-old woman who presented with subacute decrease in vision in left eye for 1 week. And the patient had mainly periocular discomfort, but no other eye pain or pain on eye movements, no other neurological complaints. And this is the chief examination findings. We can see visual acuity in right eye is 20/20, but left eye is counting finger 1 meter, which is the affected eye. Surprisingly, there is no RAPD, and the color vision in right eye is also slightly subnormal. So the patient's fundus examination showed media was clear, rest of the retina was normal. And in the left eye, we can see that there is disc hyperemia in the left eye. At the same time, the right eye shows a presence for temporal pallor, which is better seen on the red-free photographs over here, suggesting that the patient was having left eye optic neuritis, but might have had a prior episode in the right eye, which was also telling us that why the color vision was subnormal in the right eye, and there was no relative afternoon pupillary defect. Possibly a subclinical episode was happening in the right eye as well. So again, further workup, chief findings were on MRI that there was a uniformly enhancing post-contrast enhancement on the in the left optic nerve. Along with that, the brain MRI was not innocuous. We can see that there are presence of multiple oval lesions which are oriented perpendicular to the corpus callosum, which are classical lesions called as Dawson's fingers, and diagnosis was established as recurrent optic neuritis in setting of multiple sclerosis. So we saw 2 different etiological spectrums, and I'll give one more quick one, then we'll move into the current understanding. This is an example of a 25-year-old lady who was diagnosed previously as a case of multiple sclerosis and presented now with poor vision for last 2 days in both eyes. The prior neurological history was very significant. 2003, she was diagnosed as non-compressive myelopathy, which improved with IVMP. 1 year later, she was diagnosed to have left third cranial palsy. And that time, the brain MRI was noted to have demyelinating lesions in midbrain and thalamus. See that these are in the midbrain and thalamus. But at that time, she was diagnosed as multiple sclerosis in 2004, and she was treated again with IVMP with good recovery. Another episode happened in 2006 with recurrent episodes of ataxia and vomiting, and again treated with IVMP. Neuroimaging was not showing any new lesions at that time. So that was the story of being diagnosed with multiple sclerosis. We saw this patient in 2011, and at that time, the patient visual acuity was counting finger 2 meters. There were pale disc in both eyes, and confrontation field showed diffuse constriction in both eyes. The patient was given, we had diagnosed patient as recurrent optic neuritis, possibly previously diagnosed MS, but in view of different kind of lesions, we were thinking that this could be neuromyelitis optica. We started treatment with IVMP. We obtained MRI brain and orbits with contrast, and also MRI spine. The MRI brain and orbits showed did not show any brain lesions. There was a T2 hyperintense lesion in the orbit. There was not much contrast enhancement we could pick up, but the MRI spine showed a diffuse hyperintense signal involving the lower cervical and the thoracic canal, spinal cord, and the serum echoporin antibodies were positive. So the patient was diagnosed as neuromyelitis optica, and in now retrospect we could correlate everything. So in general, optic neuritis is now considered as a syndromic presentation, patient presenting with acute painful vision loss, painful in majority of patients, not in always, and there is a dyschromatopsia. But we need to define the underlying etiology, and we need to put it in the setting of one of the demyelinating syndromes, and there might be others that might come up as that things progress. So what does the literature tell us? Current understanding from the Western world says that in a prospective study done at Rochester, the annual incidence was only 4 per 100,000, and most common disease was multiple sclerosis, followed by idiopathic in 29%, accounting for about 90% of patients. And NMO and MOG were noted in only 9% of patients. That is 1 out of 10 cases. This is fortunate because they can have recurrences, and especially NMO can have suboptimal visual outcomes. In the case of children, the prospective study by PD group showed that the 1 out of 2, that is 50% of patients, have a neuroinflammatory syndrome, most common being MOG-associated optic neuritis, followed by edema, and then multiple sclerosis. NMO fortunately remains low even in this group. The recent study, great work by the SN team, showed that in 203 patients, including adults and children from India, after a detailed neuroimaging and serological testing, the MOG-associated optic neuritis was the most common, and it was seen in about 1/3 of patients, MS in about 10% of patients, and NMO remained at about 5%. A large majority, that is 56% of patients, were double seronegative for NMO and MOG. The mean age at presentation was around 30 years, and female preponderance was seen only in MS and NMO, but not in MOG. They also noticed poor outcomes in patients associated with bilateral sequential optic nerve involvement, optic disc pallor, patients presenting with retrobulbar optic neuritis, than papillitis, and NMO seropositivity. So why is it important that we subclassify the patients into one of the categories? It is because of the difference in the rates of recurrence, progressive neurological disability, and permanent vision and neurological deficits that might occur even after the first episode. So what do we have as clinical clues? This is a landmark study by Hacko and group in UK, where they try to distinguish patients with recurrent optic neuritis and find the specific clues. They found that patients with MS versus non-MS optic neuritis can lead more often to be female, adolescent, and young adults, and never presented with an edema-like picture. In contrast, patients presenting with brainstem, cerebellar, or hemispheric clinically isolated syndrome were more often found to be multiple sclerosis rather than any other demyelinating disorder. What do we know about MOG optic neuritis? There are certain specific clinical features, like they might have associated hemorrhages, they might have prodromal symptoms, they might have CNS dysfunction, they might be confused, they might have new onset seizures, and might also have ataxia. A significant number of them can present with area postrema syndrome. Majority of these patients have recurrences but present with good outcomes, and MRI can show presence of multiple large lesions, which are like effective lesions or edema-like lesions, and these can be present even in the deep white matter. So these clues tell that it is possibly a MOG-associated optic neuritis. The same study which I quoted before distinguished between MOG optic neuritis and NMO, and they found that the children with MOG-associated optic neuritis were younger, around 6 years of age. They presented with monophasic disseminated encephalomyelitis, whereas NMO was more associated with transverse myelitis, clinically isolated syndrome other than optic neuritis, and an area postrema syndrome-like presentation. So we should keep these clues in the presentation and the interneurological examination of the patient that will give us the clues. So moving ahead, what should be the current workup of the patient? We can subclassify it as an ocular workup and the serological or the systemic workup. The ocular investigations are there to quantify the visual function, such as visual fields, document structural damage, OCT of RNFL and MGCL around 3 to 4 weeks after the episode. And if you have a doubt, VEP and OCT angio might be helpful. The systemic investigations can include blood investigations, neuroimaging, serological workup, CSF analysis, and how do we decide? Well, possibly the most important investigation is the neuroimaging, which should be MRI brain and orbits with contrast for all patients, and MRI screening spine, ideally in all, but can be reserved for specific indications like recurrent disease and when we have a high suspicion of multiple sclerosis, and also serology as much as possible in all patients, which will include workup for aquaporin antibodies and MOG antibodies. We might have other spectrum of estrogen fibrillary protein antibodies later on available commercially. The CSF analysis should be done ideally in all patients, but especially when you have a high suspicion of multiple sclerosis. So coming back in little detail to how MRI can be very useful and why it is first investigation, because the distribution of lesions in the brain, spinal cord, and the optic nerve can give us specific clues. If we look at the pictures over here in this landmark article by Dutra et al., we can see that the multiple sclerosis optic neuritis usually tends to have short segments of optic nerve involvement. They usually do not reach the prechiasmatic optic nerve and the optic chiasm. The spinal cord lesions are in the white matter, they can be smaller lesions which are discrete, do not extend to more than 3 spinal segments. And what is a hallmark is the presence of multiple brain white matter lesions which are present in the periventricular, subcortical, juxtacortical areas, and also in the brainstem. In contrast, optic neuritis usually can have long segments of optic nerve involvement, can extend to the optic chiasm and the prechiasmatic optic nerve. Similarly, the spinal cord involvement tend to be bigger. They tend to involve more than 3 contiguous segments of spinal cord and can affect both the white matter and the central spinal canal, causing permanent damage. The brain lesions are usually not so marked, but can be seen in the periependymal areas and can cause specific presentations. The mild optic neuritis can have long segments of optic nerve involvement, but it is rare to have optic chiasm and the prechiasmatic optic nerve involvement. Spinal cord can again have LETM involvement, like long segments, but in the sacrococcygeal area, while in NMO, it is usually in the cervical and the thoracic spine, and there can be multiple white matter lesions, as I showed before, and there can be area postrema involvement. So therefore, MRI can be very useful, and these clues can guide our serological workup or CSF analysis given the socioeconomic constraints that we face with our patients. This study from Dr. Ambika's group at SN again showed the similar findings. So therefore, neuroimaging should be first investigation. We should obtain MRI brain and orbits with contrast with fat suppression, include star and flare sequences for picking up the periventricular lesions, and MRI spine if recurrent disease or high suspicion of multiple sclerosis. Quickly, very limited description about OCT. It is very important to obtain at 3 to 4 weeks as it can tell the progressive damage. We should remember MGCL loss is evident little earlier, about 3 weeks or so, whereas RNFL loss might take 4 to 6 weeks. And the amount of the damage is more profound with NMO and MOG-associated demyelinating disorder as compared to MS and clinically isolated symptoms. So it could be some clues. Well, the OCT can document the progression, can correlate with the visual outcomes to an extent, and can also detect subclinical disease activity. Importantly, it can also be used to provide evidence of no evidence of disease activity, that is, patient has been stable in a patient who has been diagnosed to have a neuroinflammatory syndrome. We might require OCT angiography, especially in patients, those who have atypical features and at extremes of age, like a middle-aged person presenting with disc edema and acute vision loss. In those cases, it might be confusing. So you can obtain OCT angio where the NAION patients will show specific patterns of capillary dropout, which are not seen in patients with optic neuritis and can help distinguish. Coming to the current understanding of treatment, in a classical case, most guidelines of ONTT do apply, but we definitely add serological testing and we give 5 days of initial IVMP rather than 3 days. After the acute phase management, the chronic phase management depends on what is the final diagnosis, and we need to add a specific immunomodulator depending on the etiology. So the question that remains is that, do all patients need immunosuppression, and can we wait? The patients with definite MS and NMO, better to give early immunosuppression or disease modifying drugs because they can prevent permanent disability. Whereas in MOG, about 30% of patients only have recurrences, so we can reserve for recurrent cases. Just 2 more slides.
I am in a conference, I will call you back.
So there are many newer treatment options. For the acute phase, we have plasmapheresis and IVIG. The plasmapheresis removes high level of antibodies and can be very useful in patients with recurrent episodes of proven NMO, MOG, and poor recovery optic neuritis. Similarly, IVIG can also be very useful in poor recovery first episode or recurrent optic neuritis. And various drugs like monoclonal antibodies of various classes are being used, especially in patients with NMOSD, that can be quite useful. Similarly, we have oral drugs for treatment of multiple sclerosis, which are quite good. Lastly, just a small word about COVID and optic neuritis. We have seen multiple reports that have come up suggesting possible relation between COVID infection as well as vaccination and optic neuritis. And there have been little atypical features which are reported. Majority of the people have treated them with long-term steroids, but visual recovery remained incomplete in majority of patients. And what is important is that it is difficult to give a clear-cut association. It is often presumed But we need to remember that there should be a temporal profile, that is, it is occurring within a specific time of the COVID infection or vaccination. There should be explainable pathophysiology, like the patient had the infection and then within few weeks the it progressed. We should rule out other likely causes, such as it could be other infections, and it could act as a trigger mechanism. For example, the vaccine could act as a trigger mechanism. So once this is met, we could possibly relate that after ruling out other etiologies. So a more extensive workup might be needed to rule out other causes and establish this association. With this, I'll conclude this talk. Thank you very much for the opportunity and patient.
Sir?
Yeah, that is a very good presentation encompassing all the aspects of the optic neuritis, the newer methodology by which we can analyze the status, the type of the optic neuritis, the newer AQP4, the emoji, and that help us to understand more of the type of optic neuritis, the NMO and the NMO spectrum disease, the emoji related antibodies against the emoji. So these certainly help us to better management of optic neuritis cases. I have one question to Doctor, that is about the management of the NMO. How does it differ from that of the management of the MS optic neuritis, wherein we give them a course of IV steroids and then followed up by the other oral steroids? How does it differ in that? What is a special thing that we must take into account when you are seeing and diagnosing a case of NMO?
Thank you very much, sir. Yeah, thank you very much, sir, for the kind comments and question. It's a very important question because the multiple sclerosis drugs are totally different for patients with NMOSD. In fact, if a patient with NMOSD is given drugs like interferon, the patient's chances of recurrences will increase. So coming to the specific current understanding of management of NMOSD, current guideline says that after initial phase of treatment with IV steroids, if recovery is not happening and you have a proven case, you might consider plasmapheresis early. Second thing is the chronic phase management usually comprises of drugs such as rituximab, and then patients can also be given oral drugs such as azathioprine and mycophenolate, mofetil, but these do not, especially azoran, does not reduce the risk of recurrences to the same extent as other drugs. And there are other drugs that are coming up, like I showed in the presentation, various monoclonal antibodies that can also be the futuristic best possible method for these patients. There are trials that have shown some promise with them. So the management is different in terms of drugs, in the intensity of treatment, as well as the duration of treatment. So these patients will require a long-term disease-modifying therapy with one of these agents.
That's right. I think previously we used to give this natazulimab, to the patients with the MS optic neuritis. But that drug is contraindicated in NMO because that can be injurious to the patient and not responding. Instead, we can start them on plasmapheresis, of course, and immunomodulators like methotrexate or rituximab. These can be given for the NMO, not natazulimab.
May I ask a question to Dr. Sachdeva?
Yes, please.
It's a very good, I think it's almost good afternoon. Very good afternoon to all the panelists and the speakers. So I just wanted to know, Dr. Sachdeva, how do you manage cryon patients? So sometimes we have these patients who are dependent on steroids, and then because I have 2-3 of them, and I'm struggling to manage them with the rheumatologist. So I just wanted your opinion on that.
Yes, thank you very much, Dr. Nina, for that question. I think Dr. Ambika also is there. She can also add later on. Cryon per se is like when it is corticosteroid responsive and we do not have a definite diagnosis of NMO, MOG, or any other panel, even like you might have done an autoimmune panel and you still don't have anything, no anti-Ro, anti-La antibodies are positive. So they will be very similar to the double seronegative patients, which is described in the paper by Dr. Ambika's group. Majority of them will require a long-term immunosuppressive therapy, and you can go ahead according to in discussion with the immunologist as well as with the patient, either an oral or a IV therapy, either with rituximab, IVIG, or the oral will be with azathioprine or mycophenolate mofetil. They would require the same lines of treatment as you will treat a aquaporin negative NMOSD.
Yeah, I have actually 2 patients who are currently on azathioprine and one is on rituximab. But just wanted to know, is there any, like, when can we reduce? I mean, is there any guidelines on how long we should continue the therapy, or and when can we, start reducing the drug dosage? Dr. Ambika, would you like to?
Yeah, Dr. Nina, that's a nice point what you have raised. Creon is a diagnosis of exclusion. It was called so in the ester years. So now the terminology has changed and it is put as recurrent optic neuritis with or without seromarkers, without imaging, without neuroimaging, neurological features. So if your patient, if you have only ophthalmic presentation and only recurrent optic neuritis, depends on the level of improvement following one acute therapy, you can decide the duration of your chronic supportive therapy. For example, both your patients had only ophthalmic complaints, recurrent optic neuritis with brain negative, imaging negative. You can, after the acute treatment, probably you can keep them on a long-term immunosuppression with either oral MMF or an azathioprine-like drugs. While they are on such drugs itself, if they are showing a relapse, probably you can add on one more line of a rituximab. And it is considered that rituximab is safe in any version of this demyelinating spectrum. Like what Dr. Viru has pointedly told, that you cannot touch interferon, immunomodulatory agents, in patients who are probably a seronegative NMO. If we are not going to touch interferon if the patient is going to have seropositivity for one of these seromarkers. But when they are seronegative, but still not having MS-like feature on the brain or on the neurological presentations, probably it is safe to keep them on oral immunosuppression for a chronic duration. And as you say that when to stop is a very, very difficult question to answer. It depends on how long your patient is going to sustain with the vision, showing some signs of improvement. I have patients who are on more than 1 year to 2 years also on oral immunosuppression. And after that initial 4-5 attacks, they have subdued and they are maintained. Probably it is also wiser if they throw a subsequent relapses, repeat your seromarkers. Sometimes an initial seronegativity can come out to be positive down the line. Thank you.
Thank you. Thank you very much.
Thank you, Dr. Ambika. Just, I think what Dr. Ambika said is very valid. But if the patient is relapse-free and is improving, at least 3 years of treatment with one of these drugs would be ideal. After that, in discussion with patient, further call can be taken. This is what our neuroimmunologists suggest. Thank you.
Thank you.
Thank you very much, Dr. Virender. And Dr. Nina, we are a bit short of time. Can we go through your case quickly?
Yeah. I'll just share my screen.
Okay, thank you.
Yes, Nina, please go ahead.
Case 4 is by Dr. Nina R., Senior Consultant, Pediatric Ophthalmology, Strabismus and Neuro Ophthalmology at Giridhar Eye Institute. Over to you, ma'am.
My screen visible?
Not yet.
It's coming.
Okay.
Yeah, so I'm going to share a very interesting case which has puzzled and really, taken me to a lot of people for opinion. So this was a young girl. She was brought by her mother with complaints of gradual outward deviation of the right eye noticed since last 2 years. So let me give you a bit of history. The mother had noticed that child was unable to read letters on the TV 6 years back. And that time she was taken to an ophthalmologist who diagnosed her to have myopia and was given glasses. But at the same time noticed some optic nerve swelling in both eyes They thought it was due to raised ICT, did an extensive neurological workup. She was given oral medications for a year, and then she was advised to stop the same, saying that it was an innocuous condition which doesn't need any treatment. So mother is a dentist, very intelligent lady. She was keeping the child on very close follow-up till that was not possible the last 2 years due to COVID pandemic. So in the past history, there was nothing relevant except for the history of wearing glasses. So when you look at her head posture, she had her ocular posture, everything was normal except the fact that she had a very prominent right exotropia, and alternate cover test also showed a dissociated vertical deviation. She was right suppressed and her fixation in the right eye was unmaintained, and she had a 400 arc-second stereopsis. Ocular motility was full. So when we come to the visual acuity, she had unaided poor visual acuity in both eyes. The left eye with her current myopic correction was improving to 6/24 N6, whereas the right eye was not improving further either with glasses or pinhole, and also had, both eyes had poor color vision, which was worse in the right eye. So in the anterior segment, everything was normal except for a grade 1 RAPD. So that's when we look at her fundus, and that was quite dramatic picture. You can see that this is a fundus appearance. So she had this very large peripapillary elevated disc with some amount of lot of fussy margins all around, with peripapillary bossing, which was more evident on the temporal aspect, with increased hyperemia also noted on the temporal aspect. And the vessels were seen arising normally with normal dichotomous branching, but we really couldn't make out the details about the cup and the NRR from the disc examination. So the appearance was very dramatic. It looked like as if she had severe disc edema on elevation. So this was a summary of the case. So we decided to do some investigations to find out, especially since the mother says she had better vision in both the eyes 2 years back. And so we did this OCT. Surprisingly, OCT of the retinal nerve fiber layer in the right eye didn't show a lot of edema. In fact, there was some borderline thinning in the superior aspect, and the inferior RNFL was a little on the higher side. There was some RNFL edema in the left eye. Looking at the ganglion cell layer analysis, you can see that both the eyes, the ganglion cell layer was in the late 20s and early 30s, which is definitely thin for a 11-year-old girl. And the macula also showed some amount of thinning. So otherwise, the retina was unremarkable, except for this dramatic appearance of the disc. The retina was unremarkable with good foveal reflex. So we did an OCT of the optic nerve head sections. So this is the right eye. This is the left eye. And we thought, let's do a fundus autofluorescence. And that's when we saw some hyper autofluorescence lesions on the all around the disc in the right eye. So we did an ultrasound B scan, which showed features in favor of optic nerve head drusen in both the eyes. A flash VP was also done, which showed prolonged P100 latency in the right eye compared to the left eye. Both eyes, the amplitudes were reduced. So we did an MRI of the brain and orbits, which was within normal limits except for bilateral thinning of the optic nerves. She was advised a lumbar puncture, but the patient refused the same, saying that she doesn't have any features of raised ICT. The mother refused the same. So she was advised a neurology opinion, and they referred us back to us, saying that she doesn't have any neurological issues. So then we decided to do an OCTA because there was something in the peripapillary region was not looking right, and she was going in for a progressive compressive optic neuropathy. And the OCTA showed some suspicious choroidal neovascular membrane on the temporal aspect. You can see the flow signals along the peripapillary CNVM and the network corresponding to the flow signal here, which was very evident in the right eye, but in the left eye, it wasn't so obvious. So when we asked them to show the old pictures, the mother had her older records. I don't know if you can see this. You can definitely see that she did have an abnormal disc. This was 5-year-old picture, abnormal disc that time. But when you compare it with the current fundus picture, you definitely know that things have actually progressed. The whatever swelling or the compression is there on the optic nerve head has really progressed. So we were in a dilemma what to do, but definitely we consulted our retina specialist, and a diagnosis of peripapillary CNVM with possible optic nerve hydrogen producing a compressive optic neuropathy was made. Her previous records showed she had 618 vision in the right eye and 69 vision in the left eye about 2 years back. So an infiltrative pathology was also ruled out by doing an extensive hematological workup. Everything else was within normal limits. So anyway, patient was advised an injection ranibizumab, which due to some traveling issues, she took it from a local hospital. And she sent me this picture post the injection. This is from a different machine. You can see that nothing much has changed in the right eye. Left eye, this is the left eye. The recent picture which she sent me about a week back. And this is the OCT which was done at their center. If you look, it's a different machine, you can't compare, but what you can see is that the right eye is almost the same, but the left eye, the inferior RNFL is coming down. It's becoming thin. That's what I thought. And the macular thickness also was reducing in both the eyes. It's not a direct comparison, but I thought it was still progressing. So I don't know what to do next. She's asking me, and I think they've gone for a second opinion to Aravind also, and or some other leading hospital, where they were advised to undergo injection ranibizumab only. But I don't know what next can we offer her. I would like the expert panelist's opinion on this case. Thank you.
Thank you, Dr. Nina. I request the opinion of Dr. Ambika on this case.
That's a very nice case, Dr. Nina. As you had pointed out, the child has developed a secondary retinal pathology on top of a pre-existing probable pseudodisc edema. And we could not quantify how much of vision she had in due course lost due to the retinal etiology, because whatever the changes are, mostly it is in the peripapillary area. And macula also was not that much affected. That's what you could show in your findings. My question is, was there any other symptoms of raised ICP or any other systemic features which you could recollect from the child? Any MR venogram abnormalities? Was the child?
MR venogram was also done. It was perfectly normal. And she's actually a very thin, lean girl, 11-year-old. She has not started her periods yet. So, but we did a gynecological evaluation, and an ultrasound was also done. That was within normal limits. She's not obese also, so she doesn't fit into the typical IIH this thing. But her mother says at the time of first, suspicion, about 5 years ago, when they thought that the discs were looking funny, they did a lumbar puncture. That was apparently normal, and still she was given a prophylactic course of Diamox by the local neurologist, who after some time agreed with the ophthalmologist that this was optic nerve hydrogen and she didn't really need any further treatment on that. And she was symptom-free all these years. When in last 2 years only, the mother, actually she says she just noticed it very accidentally that the eye started squinting. And then when she started checking her vision, she found that it had dropped from 618 to the current CF 1 meters. The child never complained.
Because as you said, if there is a progressive vision drop and the disc appearing something like pushing the disc forward with probable CNVM or on, infiltrative is one thing which probably we have to keep repeatedly evaluating. And you had done the hematological workup to rule out an infiltrative. Is there any MRI optic nerve sheath or the optic nerve per se changes in your subsequent imaging?
No. We repeated the MRI again. MR optic nerve and optic, everything was normal. We did a double check with the radiologist. There was nothing.
Okay, because my differentials would have been only an infiltrative if there is a progressive drop in vision apart from a peripapillary, and that too, the CNVM on an octave was only picked up on the right eye, isn't it?
Yes, yes.
And what happened to the left eye? Then why the left eye is progressively dropping the vision? So that is something which is get missed, and probably you have to escalate your systemic evaluation and rule out if there is any nerve sheath abnormalities. Go on a 3D fine cut sagittal at the optic nerve, just around the optic nerve head insertion. It could give you some clues, I guess. Thank you.
I have one question. Yeah, ma'am.
Can I add a point?
Yes.
Dr. Sandhya.
Yeah, madam, actually we had one case, young male who was mock positive, and he was given injection methylprednisolone, and later he was started on even injection rituximab, and he finished actually 4 doses of, that is 3 doses and 2 booster doses, and along with rituximab he was also having 30 milligram Vicelon. But since he developed the CSR, we had to taper the Vicelon, but he developed optic neuritis again on even after this rituximab. So should we stop rituximab and start on another immunosuppressants, or what should we do?
Probably your patient is not able to tolerate steroids. We can try the steroid sparing drugs. So MMF is working well for our patients. So if you give you can go on for the next cycle of rituximab, and you can continue the patient on oral MMF or oral azuran. That will give you a good effect, provided I take the MRI brain is negative and there is no other features apart from only ophthalmic symptoms. Because we have patients who have gone on cyclophosphamide injections also, because they had additional neurological findings. So if you have only a pure optic neuritis, probably MOG related recurrent events, try IV steroids, see for a short oral taper and switch on to the steroid sparing drugs. And if you still get another attack, maybe go on earlier with the rituximab. I feel 2 shots of rituximab, you just give that treatment-free interval to see for the response, and then escalate to the steroid sparing drug.
Actually, madam, he had an episode of seizures, but MRI brain and all was normal. Okay, okay, madam.
Thank you.
Thank you. Thank you very much. Thank you, everyone, for the active discussion. Dr. Sandhya's presentation, we'll have it in the 4th session due to shortage of time. I'd like to thank Raju sir and all the panelists and for the active comments. A special thanks to Dr. Virender. Dr. Virender's hospital is having a NABH inspection today, but in spite of that, he has made time to be with us. Special thanks to Dr. Virender. And now we'll go to the 4th session. I'd also like to welcome Vijayaraghavan sir, senior ophthalmologist and renowned teacher, passionate teacher, I would say, to this symposium. And we'll now go to the 3rd session.
The chairperson for the 3rd session is Professor Dr. Padmaja Krishnan. Madam is retired as professor and head of the department, Calicut Medical College, currently professor at MES Medical College. She is an excellent teacher, great orator, many times talks offhand for hours without a PowerPoint presentation. Apart from ophthalmology, she enjoys reading, knitting, and cooking. One who doesn't like embarrassing superlatives for her, but an inspiration to many. We welcome Padmaja ma'am to chair the session. Our panelists are Dr. NSD Raju, Dr. MD Francis, and Dr. Revati Ramesh. Keynote 5 is Practical Approach to Cranial Nerve Palsies. Speaker is Dr. Ambika S., Director, Department of Neuro Ophthalmology, Shankara Nethralaya, Chennai. Madam's areas of interest include optic neuritis, demyelination, ocular myasthenia gravis, mitochondrial optic neuropathies, and neuroimaging. Her awards, a few, include Best Paper in SD Atwale Award, AIOS 2014, Best Paper Award at ICTRIMS 2015. She has authored many publications in ophthalmology journals, Atlas in Neuro-Ophthalmology, Atlas in Neuroimaging and Ophthalmology. Many chapters in Neuro-Ophthalmology textbooks are authored by her. She is an invited speaker in many national and international ophthalmology, neurology, and neurosurgery conferences. Welcome, ma'am.
Thank you so much for the warm introduction. And I take this opportunity to the team of the organizers, Kerala Society of Ophthalmic Symposium, as well as a special thanks to Dr. Thomas Arun for having me here. And let me start sharing my screen. Is it visible?
Yes, ma'am.
Okay. So I'm given a topic on practical approach to deal diplopia with cranial nerve palsies. This is not something which is very unusual in a neuro-ophthalmic clinic. And I don't have to go into this anatomical slide where We all know that this 3-4-6 is closely knit with the brainstem, and they all travel together in the subarachnoid space, enter into the cavernous sinus, and get into the orbit, supplying the respective muscles. So a detailed history taking is the key in any neuro-ophthalmic symptom. So considering a diplopia, you have to find out the onset and the progression, and whether it's monocular or binocular, whether it's horizontal or vertical, and also give an importance to the variability of the symptoms. If there is any variability which is getting better with the sleep or getting better in the mornings, you have to give importance to that history. And if it is painless or painful, and associated symptoms like headache with or without vision loss, and also give a keen interest on the systemic illness like diabetes, hypertension, past history of TB on ATT drugs, and a herpes zoster or a HIV infections. And find out if it is a recurrent diplopia, because all these history symptoms, what you're going to fetch out from the patient, are going to guide you in deciding the diagnostic modalities, what you're going to choose down the line. And a past history of trauma or a malignancy or surgery is also important to be asked for. This is a basic algorithm what we follow. If it is an isolated cranial nerve palsy or not, first of all, check if it is associated. Is it a traumatic? If it is yes, then probably treat accordingly. If there is no history of trauma, confirm it is a congenital or an acquired. If it is a congenital, yes, we can observe. And if it is significant and if it is not a congenital, probably a vasculopathic, you can observe it if the vasculopathic events are under control. You cannot observe it when there is a progression or associated features. If it is going to be a non-isolated, non-congenital, do not hesitate in going ahead on imaging. So when do you watch a cranial nerve palsy? This is an important question. So age, I feel probably this is only for the theoretical purpose. They do say that you can watch cranial nerve palsies beyond 50 years, but you be case specific. And any isolated cranial nerve palsy with positive ischemic risk factors, no other associated neurological symptoms or signs like raised ICP, no eye pain, no eye redness, no optic neuropathies, particularly optic disc edema. There is no past history of trauma or malignancy. If there is a sign of spontaneous resolution or no recurrence, probably we can watch these cranial nerve palsies. This is a very complicated slide. You can take the reference over here. This gives a detailed workup of all these individual cranial nerve palsies, where they all say if it is going to be congenital, probably just watch. If it is going to be an acquired, just if you think that it is acquired, which like you have to image, crossing a particular duration, do image these patients. So these are the list of blood investigation which we customize to our Indian patients. So get a complete hemogram. Do not forget, giant cell arteritis can also cause a cranial nerve palsy, and it will not only cause an non-arthritic ischemic optic neuropathy. So if you see an elderly patient, painful cranial nerve palsy, probably you have to ask for ESR and CRP also. And get these granulomatous, autoimmune, and other like compressive events like thyroid, myasthenia, all has to be added in your workup. And thanks to the pandemic, yes, you have to add a flavor of this, either a post-vaccine or a post-COVID, because we do see a lot of cranial nerve palsies post-COVID and as well as post-COVID vaccinations. So check the blood pressure and maybe think of doing a LP and a CSF analysis if it is really warranting. And do not forget to roll out a myasthenia. So when do you image a cranial nerve palsy? When you see a chronic cranial nerve palsy, when there is no response by 4 weeks, I escalate even by 4 weeks. The ideal book teaching is more than 6 to 8 weeks. But if it is a multiple cranial nerve palsy, if you see a pupil involving third nerve palsy, do not hesitate imaging. And if it is an associated optic neuropathy, headache, tinnitus, and red eye, and if it is a painful ophthalmoplegia, and if there is a past history of trauma or malignancy, and an associated history of demyelination, past history of demyelination, thyroid eye disease, myasthenia gravis, tuberculosis, and HIV, all these group of diseases will warrant an MRI brain in orbit. And there is definitely, that is the imaging of choice, and do not ask for a CD brain in orbit because we tend to miss many findings in that. And even doing a neuroimaging MRI brain, just find out that if the center is having the sufficient technology, because sometimes we do have an inappropriate cuts, inadequate sectioning can deal to miss the lesion what we are looking for, and particularly mention to your radiologist that this is what you are looking for. Trace the third nerve, trace the fourth nerve. I am suspecting a fourth nerve lesion along its course. Sometimes that will be rewarding and a positive imaging finding. Yes, CT brain has its own role, and particularly a post-trauma, when you suspect a metallic foreign body, in case of thyroid eye disease, to see for the orbital apical compression. In addition, you can use a CT, but also it has a role in the conditions where there is an absolute contraindication for MRI in these instances. So managing a cranial neuropathy, yes, we all observe the isolated cranial nerve palsies to a certain extent, particularly when they have vascular risk factors, without any of those red flags, what I had mentioned. Observe them for at least 2 to 3 weeks, keep them in close follow-up. And probably if the diplopia is troubling, we can give an option of monocular occlusion. And yes, steroid has a limited role in a position of inflammatory etiology, but make a point that rule out there is no associated infective etiologies. Spectacle prisms will helpful to a certain extent. And there's a very limited role of Botox, and surgery in a non-resolving paretic squint may be an option. So let me go across few clinical case scenarios. This is a 60-year-old female with a sudden onset of double vision. She's a known diabetic and hypertensive, and you can see visibly there is a limited abduction in her left eye, and the other extraocular modalities are full. So this is a left sixth nerve palsy with a HB1AC of 8.9%. So this is a condition where we can give her a choice of wait and watch. And with a strict glycemic control, her extraocular motility improved by 4 weeks. So you don't need any management or a further evaluation at this juncture. But the same thing, again, another 60-year-old female who came with a sudden onset of headache and a double vision. And she's also diabetic and hypertensive, but this history made us to not delay the neuroimaging. She had a past history of uterine malignancy and was operated for that. So this left sixth nerve, you can see that she's not able to abduct her left eye, and this left sixth nerve doesn't warrant a wait and watch. Although she is a diabetic and hypertensive, we have to go ahead and image her, and this is what we fished out on a neuroimaging. She had an extensive necrotic lesions in the left cerebellum with a lot of perilesional edema, and it is also causing some amount of compression to the fourth ventricle. She had a extensive metastasis secondary to the uterine malignancy. And in children, I feel there is no point of wait and watch. Straight away, if it is an acute ESO, this child has a visible left abduction deficit with a 20 days old history and an acute ESO, no point of waiting, image the child. And this is what we picked on her MRI, and it was a well-defined hypointense lesion with a rim of hyperintensity. It was cystic and partly necrotic, and it was a pilocytic astrocytoma causing a nuclear left sixth nerve palsy. And with a history of trauma, this gentleman came with a history of trauma and a vertical diplopia. And we all are aware that fourth nerve is very common and is prone to traumatic palsies. But also you rule out, you do a FAT scan of his old photographs. If a patient comes, whether is it a decompensated pre-existing superior oblique or is it a post-traumatic? Nevertheless, the treatment doesn't have a big difference if the patient is able to manage with the prisms. You can see a visible right hypertropia. He had a AHP also. He had a right hypertropia, which wasn't on the left gaze and the right tilt. So he did well with prisms. So we observed him over a period, and then we gave him a trial of prisms, which did well for him. And coming to the third nerve, I think the previous speakers have already highlighted that third cranial nerve, you have to differentiate in these 3 genres. Is it complete or partial? Is it pupil involving or pupil sparing? Is it with or without ischemic risk factors? We all know this divisional palsies. If it is going to be a complete cranial nerve palsy, pupil sparing with risk factors, yes, there is some scope of wait and watch. But if any of this sectoral, upper division, lower division, it's partial, then do not wait and watch. If it's a partial cranial nerve palsy, it's better to get an imaging done. So this is a patient who is 60-year-old female with a random blood sugar. She got to know that she's diabetic only after she developing this cranial nerve palsy, because we do have a group of patients in India who doesn't even have a basic evaluation. So always get a blood evaluation. You may be the one who is cracking that he or she is going to be a diabetic. So this lady turned out to be something like that. She came with an acute ptosis. It was pupil sparing, complete right third nerve, as you could see here. And she had a random blood sugar of 304. So this pupil sparing third nerve could be watched with a strict diabetic control because it was a complete third nerve. On the other side, this lady, she is a 68-year-old female who came with a 1-week onset of ptosis and diplopia. She also had a poor control of diabetes and hypertension. Interestingly, she had a chronic headache and she was operated for a ventriculoperitoneal shunt 2 months back. So she said that she didn't have this at that time. And she had a right third nerve, which is pupil sparing. See, with a poor control of diabetes and hypertension and a pupil sparing, I felt like, okay, you're also having an ischemic, but somehow this past history did not allow me to keep her go off my clutches. So I told her, why don't you come back for a re-evaluation? So the same patient, after maybe 3 weeks, her right third nerve became pupil involving. So in fact, she had a massive intracranial bleed. That was the reason why she had a bleed removal. And you could see the VP shunt tube also in place. And you could see the small PCOM over there. And on a DSA, it picked a right PCOM aneurysm, which slipped the earlier investigation. And probably she did not have a pupil compression at that time. And she has developed because she didn't have this right third nerve at the time when she had this headache and the intracranial bleed. But you should also remember that ocular myasthenia gravis is a great mimicker. So always watch for patients who come with ptosis and diplopia. A simple eyes test in the clinic or even a tensilon test will be much rewarding before you are planning for the next line of management. So multiple cranial nerve palsies do happen in these locations, an orbital apex syndrome, SOF, and a cavernous sinus. See, although we coin them with this depending on the cranial nerve involvement, they all not are miles apart. So when a patient comes with an SOF, he may easily drift into an orbital apex depending on the associated cranial nerve involvement. In such a condition, do a detailed neuroimaging, rule out if there is any history of trauma, any sinus procedures, because we see a lot of post-FES type of orbital apex lesions where there is an acute vision loss, but we also watch out before starting steroid, confirm that it is not an infective etiology. And if it is going to be a SOL, we all know that we do go ahead with a mass removal, but also watch if it is going to be a metastasis like what I had shown. So rule out a vascular, infective, and an inflammatory etiology based on these battery of investigations, what I have suggested. Again, I'm repeating, cranial nerve palsies can be due to giant cell arteritis also. Keep a watch on that for the symptoms in an elderly patient. This is again a 56-year-old diabetic hypertensive patient who came with an acute painful eye and a complete restriction of all his extraocular movements. And this was almost like a fixed eye. So this patient had a MRI showing a very bright signal sitting over the right orbital apex, cavernous sinus, and the SOF. Complete involvement. All his movements were restricted, and his biopsy turned. We went ahead and did a transnasal biopsy, showed a aspergillus for this guy, and we are seeing a higher incidence of mucor, as we all are aware post-COVID. And this is his post-treatment photograph, where he had a complete resolution of symptoms. And not multiple cranial nerve palsies has to be alone in the superior orbital and a cavernous sinus picture. It has to be, see, this guy had a herpes zoster infection where he had a limited left sixth nerve and he had a lesion in the left cavernous sinus. So what I mean is, even in the, if it is going to be an isolated cranial nerve palsy, we can still see a cavernous sinus lesion. So a young patient coming with a painful in a cranial nerve palsy, do give importance to these conditions. And this is another guy who also had an isolated left sixth nerve having a lesion. And this patient, this is another lesion where we had a small AV malformation like what one of the previous speakers had shown. This guy had a small AV malformation, almost in the same location what I saw in one of the previous speakers. So this is a 47-year-old female who was referred to us as a query CCF or a thyroid eye disease because she had a painful double vision, which improved previously with steroid treatment. Her thyroid profile was normal. She had a bilateral sudden drop in vision for 10 days, and she had a painful double vision, and her right eye vision was slightly better than the left eye. She had all movements restriction, which you can see here. See, this is what the eye, almost like it's a tight orbit with gross chemosis, severe redness. All the EOMs are being restricted. So this is the fundus appearance. So she had a bilateral disc edema, right more than the left, and this is her visual fields. So you could see that both the eyes showing a central depression. So we are dealing with, yes, we all, as we expected, there's a gross thickening of the extraocular muscles, but interestingly, it is not only a tendon sparing thickening, which is very characteristic for a thyroid. So this patient, we had asked with a provisional diagnosis of IOID, myositis, TED, or an IgG4 orbitopathy. Yes, she had a marginally elevated anti-TPO. We involved an endocrinologist and a rheumatologist. We went ahead with a steroid, but I just requested my plastic friend, why don't you get a biopsy of the muscle? Because it's not very typical for a thyroid. And this is what we picked on the biopsy. And that was a optic neuropathy causing gross inflammation of the muscles. That was a sarcoid-related myositis, which also was mimicking like a thyroid eye disease. And this is the post-treatment photograph of the same patient where there was an absolute resolution of the vision as well as her double vision. So this is a 41-year-old female. Again, she was referred to us as thyroid eye disease. She had a ptosis and squint for 2 years, and she was a hyperthyroid, and she had a drop in vision in the right eye, and left eye was apparently normal. See, she had a CT orbit done locally, and they showed that the thyroid was not very classical because the muscles were not thickened. So she has a ptosis. If you could see, she has a ptosis with a vertical movement restriction, adduction restriction. And if you could remember, the right eye only had the vision drop. Left eye had a better vision. What do you see in the vertical movement? You see some lid lag when she looks down. So probably what we suspected that she is having a chronic right third nerve compression and an aberrant regeneration because the eye is quiet. It's not behaving like a thyroid. So it's a quiet eye with what you see here is an abnormal widening of the palpebral fissure. You see a lid lag on down gaze. This is a sign of right chronic third nerve compression and an aberrant regeneration. Here, you do not need a CT orbit. And one more visual test which helped us is this. You see the visual fields, it's a gross temporal loss in the right and the left also showing a temporal field loss. So there is a visible compression at the chiasm, and so we went ahead and did an MRI. So her levels, unfortunately, she stopped imaging on CT at this level. Probably if they would have moved slightly up, they would have picked this lesion for her. So what she wanted is an MRI brain in orbit. It was a massive stellar suprasellar mass. This is the post-treatment, post-neurosurgical visual fields. She had a good recovery of her vision, and also the double vision also settled. So to conclude, diplopia evaluation requires a thorough history taking and a workup before planning your neuroimaging. Differentiate whether we are dealing with a vertical or a horizontal diplopia, and localize the diplopia, and do ask the radiologist to trace the particular cranial nerve, because many a times you may make the correct diagnosis and end up with a negative neuroimaging, because if the neuroimaging is inadequate, we may not be able to pin the diagnosis. And always ask for a MRI brain in orbit with the contrast. And isolated monocranial nerve palsies also can be dangerous, as I had shown. They can also have, in spite of having vascular risk factors. I think in India, almost more than 60–70% of population is going to have diabetes and hypertension. So do not get carried away with the vascular risk factors. If your clinical clues are more towards another etiology behind, go for the imaging. And always have a multi-speciality approach in managing diplopia, because it can be life-threatening at times, and you may be their saviors. Thank you so much for patient listening.
Thank you so much, Dr. Ambika, for not only the detailed, exhaustive, practical approach to diplopia and cranial nerve palsies, but also the very, very many practical tips that you gave us. Can I just make, rather than a question, can I pass a comment? When this happened the first time, we thought it was one-off, but it happened the second time, and that's the point I want to make. We had a patient with ptosis. He was the bystander of somebody on the neurology board, and the neurologist decided that it was myasthenia on the basis that he kept saying he felt better in the morning and the ptosis was worse in the evening. And somehow they had noticed only recently. The same thing happened recently with the classic. We had to lock horns with the neurologist again, where there was a classical third nerve, unilateral complete ptosis, restriction of all the movements. But the basis for diagnosing myasthenia was that the patient kept saying, I felt better in the morning. And in both these cases, the problem is that they were using the occipitofrontalis in the morning, and probably that muscle too tires out towards the evening. And when we got the first person who we thought was congenital, when we got him to take the picture of the ptosis in the morning, it was the same as in the evening. So in these days of mobile phones and digital photographs, I'm making a case that when you're going to make a diagnosis based on patient symptoms, maybe it's valuable to have, as if you were there, to get a photograph taken to prove that it was what they say it was, or it was not what they said it was. So in both these cases, the ptosis remained the same, and the diagnosis on symptoms, I think, is not valuable. That's all I have to say. I know we are running terribly short of time. So if anybody else has questions.
Thank you very much, Ambika Madam, and thank you, Padmaja Madam, for your comments. Now we'll have Dr. Matthew James will present a series of cases, which and I'm sure we can have a very good discussion in relation to that. Dr. Matthew, as Pradeep Sharma sir had mentioned, he had started the study on the use of steroids in non-arthritic AON and proved that the study showed that they were not of much use. Over to Dr. Matthew.
Dr. Matthew James is consultant ophthalmologist at Medical Trust Hospital. Over to you, sir.
Good afternoon. Since we are running short of time, I'll be running through the cases. I had planned 4 cases. The first case, we'll straight away go to the first case. It was a 64-year-old male who had undergone a renal transplantation 3 months prior and was on immunosuppressants. He had a mild graft dysfunction, and associated with that, he had a liver disease and a cardiac issue. He presented to the casualty in the with the ENT department with complaints of headache and epistaxis from the right nostril. On the same night, he underwent a nasal packing for the epistaxis after a thorough nasal examination. But the following day morning, he suddenly developed ptosis of the right eye and he developed diplopia. Now he started complaining that it is the problem of the ENT procedure that the ptosis and diplopia started happening. On our examination, he was having a vision of 6/9 in both the eyes. IOP was within normal limits. The right eye had ptosis and it had a mild proptosis. His adduction, circumduction and deosumduction and intorsion was restricted in the right eye. Abduction was normal. The left eye movements were normal. The pupils were equal and reactive. There was no RAPD. In the fundus was also normal. There was no vessel tortuosity or no papilledema. So with this basic findings, then we went ahead with the other cranial nerve examination. We did a corneal sensation test, and that showed it was reduced on the right side. There was no ocular bruvi or any pulsation palpable on the right orbit. The retropulsion also didn't show any resistance in the right eye. Now with this basic information, let's see what we can. This is the clinical picture of the patient. As you can see, he had a ptosis of the right eye. Abduction was normal in the right eye. The adduction, elevation, and depression is affected. The pupils are uninvolved. Keeping this clinical picture, we'll try to analyze what could be the possible solutions. Now, as you know, the nuclear lesions, if it happens in the midbrain, then you should have either a bilateral superior rectus or a bilateral ptosis, which is not there in this patient. So let's leave that side. And the other lesions which are on the path when the optic nerve, the third nerve, is coming out of the midbrain, the red nucleus and the cerebral pentagonus. Either you should have a hemiparesis or a tremor of the opposite side. So since those are not there, let's leave those midbrain lesions aside. I'll not get into the vascular things. So once the third nerve comes out of the midbrain, now our story starts. So when it comes out of the midbrain, actually it has passed through the pia mater, then cross the subarachnoid matter in the subarachnoid space, and then reach the dura. And from the dura, within the dura, it enters into the cavernous sinus, as you can see in the second picture. Now, in between this, actually the third nerve is going between the posterior cerebral artery and the superior cerebral artery, and there is a parallelly lying pecom artery which is there near to the third nerve. Now, nowhere here we are getting actually a fourth nerve involvement. So let's leave those points also aside. Now, when we come into the cavernous sinus, as you can see, the third nerve and fourth nerve are lying nearby, and the trigeminal nerve divisions are also there. So we said that the third nerve was involved, the fourth nerve was involved, and of the corneal sensations and the forehead sensations were decreased. So taking those into consideration, the V1 segment of the trigeminal nerve is also affected. Or it could also be in the superior orbital fissure. So now we have two options which is left, which matches with our clinical picture. One is the cavernous sinus or in the superior orbital fissure. Now, cavernous sinus, three things that come into my mind when I analyze this case is because the patient presented with nasal bleed, epistasis. So let's consider a nasopharyngeal carcinoma which is spreading into the cavernous sinus, which has caused the epistasis and also caused a third nerve, fourth nerve, and the first V1 division of trigeminal nerve involvement. Or else it could be a cavernous aneurysm, which is causing the similar nerve issues, or it could be even an infection which is there involving the cavernous sinus due to an aspergillosis. Now, keeping this in mind, already the patient, when the patient was being seen on the first day, MRI had already been done. So that was reported normal. Now, as we had already discussed in the pupillary, the session on the pupil, if there is a complete third nerve palsy with the pupils not involved, then you come into the low risk group. So considering this patient, actually it was a low risk group of complete third nerve palsy. So MRI with MR angio may be done, may not be done. That is up to the person who is analyzing the patient. Now, anyway, this patient had already undergone an MRI brain screening and it was reported normal. Now, then comes the issue. Then what is the reason for this? He had undergone a renal transplant, so we cannot do a contrast MRI. So since he had a headache, we thought let's go with the LP also. Here he was on immunosuppressants, so the neurologist did a LP and that came out to be normal. He was admitted, he was an IP patient by then, and then the next 2 days he suddenly developed the left eye mild ptosis and left eye medial rectus involvement. This is the right eye involvement. As you can see, the adduction is involved. Elevation was also involved. Abduction was perfectly normal. Elevation is affected, and depression is also, but depression is there partly. When the other eye was involved, when the other eye was checked, that also started having medial rectus involvement. The other eye movements were normal in the left eye. So keeping this, then we had to go because the one eye was involved and now this other eye is also involved. Now we cannot just stand by and say that the first MRI was normal. So we had to go think of the second imaging. We had to convince our nephrologist, even though he was a renal transplant patient, to go ahead with a contrast MRI and with a MRA. So in that, the second imaging, what we found out was there was a large saccular aneurysm of the right internal carotid artery, which was there in the right cavernous sinus, pressing on the midline. Now you can see that this is the T1 image where you can see a shadow of the aneurysm, thrombus aneurysm basically, and that is more clearly visible on the T2. And this is the TOF image, time of flight image, where you can again see the artery clearly with the aneurysm, thrombus aneurysm. Now, so that we found out that the aneurysm is the cause for the right third nerve palsy. But now we had a new situation in hand. We had a left eye involvement, which is not picked up even with contrast MRI. So we had to find out what was the reason for the adduction deficit in the left eye and a mild ptosis, of course. So So with that clinical features, then we again went for the ENT review. They again did a nasoendoscopic examination. They planned that they will do a FES to take out if there is any lesions which can be seen. So when they did the endoscopy, they found out that the sphenoid ethmocyte was completely blood filled, and by that time, actually the right eye, the pupils also started getting dilated. So by the 4th or 5th day, the right eye showed anisocoria. The left eye was involved. The right eye was completely involved. Now with this, the ENT surgeon told, like, let's go ahead with a CT examination also to find out if there are any sinus collections or any other swellings in the bony tissues, basically. So when that was done, they found out that there was periosteal collections in both the orbits. Now, this is a point where CT proved to be a better diagnostic tool than MRI in this case, basically. Even the contrast MRI could not pick up this finding. Probably it was early phase of the disease, but by this stage in the CT, they could find that there was a subperiosteal collection in both the eyes, both the orbits. So now this could explain the right eye involvement. The right eye medial rectus was involved because of this periosteal collection. This is the periosteal collection. You can see the two humps which are there on the right and the left side. So now our diagnosis was basically based on what is responsible for these collections. So the FES was performed, a specimen was taken from that, and we found out that there was Aspergillus fumigatus, and the patient was started on treatment for the same. Now, so our final diagnosis was basically an Aspergillus infection which had eroded into the sinuses, causing an internal carotid artery aneurysm. These are something called, it is very rare actually, mycotic aneurysms. The infection actually predisposing to an aneurysm. So, and that aneurysm caused a right cavernous sinus involvement, which caused the 3rd and 4th and 5th nerve in Palsies and periosteal collections in the both orbits. So now there were a few doubts which were still not answered. Why is the aneurysm not involved the pupils very late? The reason could be that in the cavernous sinus, actually, the internal carotid artery lies below the oculomotor nerve, actually. So when the oculomotor nerve, in the oculomotor nerve, the pupillary fibers are on the dorsal end and the periphery. So dorsomedial end, basic dorsal end. So the aneurysm which is there from the internal carotid artery might involve the pupillary fibers late, unlike the PCOM aneurysm. But the PCOM is actually sitting above the oculomotor nerve. An aneurysm which is there can directly bulge the dorsal surface of the oculomotor nerve. So in internal carotid aneurysm, you can have a pupillary involvement later, like in our case, basically. So the take-home message from my case, the first case would be that incomplete third nerve palsy without pupil involvement does not rule out an aneurysm. So it is always better to do a MRI with MRA or a CT angio if possible, whenever you are suspecting a third nerve palsy, even if the MRA, even if the pupils are not involved. And if you don't hit a diagnosis even with that, and if you have more than one nerve involvement, always take a contrast MRI. This is the case one. I would leave the first case for discussion.
Beautifully presented, beautifully discussed. What do the panelists have to say?
Yeah, very good case, Dr. Matthew. Can I make a comment?
Yeah, sure.
Yeah, was there any orbital signs in the presentation? Because the whole sinus was filled with the Aspergillus mass and it was eroding into the orbit also, isn't it?
Yes, yes. Yeah, it was eroding into the lamina praeparatio, into the medial part of the orbit, basically.
So that was not picked up on CT?
No, it was, the CT was done on the last like, I mean, the later, it was done on the 5th or 6th day.
It was not picked up on MRI, very surprising.
No, it was not picked up on the MRI.
Yeah, because I've had patients who were presented with optic neuritis and turned out to have allergic fungal sinusitis. And it has been beautifully picked up on MRI. So I just wondered why this was missed.
They kept on reporting that there was a mucosal thickening of the sinuses. It's actually, when you retrospectively think, they can say that there were few collections. But in our clinical scenario, many times the radiologist, when they think back, they will say that the initial scans also were showing certain features. but it's the clinical diagnosis along with the radio diagnosis which actually finally helps the patient actually. Had we not thought of the clinical scenario,
persisted and you proved them wrong. Kudos to you. So that's the spirit.
so shall I go to the next case or?
Yeah, Matthew, I think we are a bit short of time. Can you keep it and then we'll see on the session. We'll come back in session 4.
Yeah, sure.
Okay, thank you. Rashmin, can I Vijayaraghavan sir talk now?
Yes, sir.
Yeah.
Keynote 6 is Practical Approach to Nystagmus by Dr. V.R. Vijayaraghavan, sir. He served as a PG teacher in various colleges for 30 years and retired as Professor HOD from Coimbatore Medical College. Presently, he is serving as Academic Director and Consultant at Arison Eye Hospital and Postgraduate Institute, Erode. Dr. V.R. Vijayaraghavan, he is a visiting PG teacher in ophthalmology at various hospitals. He has published more than 30 scientific papers in many international and national journals. And the awards he has got include the Sainya Seva Medal in Army Medical Corps for meritorious service in Jammu and Kashmir, and the famous Professor T. Gopinatha Menon Memorial Oration Award at August Ophthalmica in 2013. He has got the Lifetime Achievement Award in IMA Coimbatore and the Dr. J. Agarwal Award for Excellence in Teaching in 2020 in Tamil Nadu Ophthalmic Association Conference in 2021. Over to you, Dr. Vijayaraghavan, sir.
Thank you, Dr. Lakshmi. I thank Dr. Thomas for the great opportunity. And in fact, I'm really happy to be associated with KSOS for the past, I think I joined in the KSOS membership, I think 1988 or 89. That time only I joined. So my number is, that's why I have got great association. I have got a liking for KSOS always. My talk is on nystagmus. Nystagmus, everyone knows. It's a voluntary, it's an involuntary to and fro oscillations, rhythmic. But for us, when you get a case of nystagmus, we always have tough time. We always fear as if something is going wrong, and we refer the patient to neurologist. It should not be the case. It should not be the case like that. We always examine. We can give our opinion. Then we can come to a conclusion just by noting what type of nystagmus is this. You can fairly come to a conclusion of which area is affected in the brain or which part of the brain. So then you can refer the patient for the management part. And some of the nystagmus even we can manage by doing surgeries and all. See, this is what you know that. What is nystagmus? I already told you. It's a to and fro oscillations, rhythmic, involuntary. There are something which may be involuntary only, but not rhythmic. They are called as nystagmoid, nystagmus-like oscillations. See, this is what you might have seen. You might have seen this, at least in Kerala. It's a famous Kathakali dance, Kathakali. They practice eye movements and all. So naturally, imagine this patient comes to you without his dress and all. We are liable to miss. Suppose that fellow performs this act in front of us. We are in dilemma. So it's a voluntary nystagmus. It's called as voluntary. That means they can practice. With practice, you can do all these things. That's why we can call it as voluntary nystagmus. Some persons can do that. Now imagine nystagmus. What's happening here? We have got two types of movements. We got a slow movement. We got a fast movement. So many things are there. But normally, what is the goal of our eye movement? Suppose you got fixed an object is there, you have fixed. It just remain in your retina, macula for some time, fovea for some time. That's called image of object steady on the retina. That shows the importance of your movements. The movements are actually, we've got two types, foveating and defoveating. That means the movement takes the object towards the fovea. That's called foveating. Takes it away is called defoveating. This is a basic thing everyone knows. Then I told you, the movements can be slow movements or fast movements. One thing, what are the slow movements now? What's the importance of slow movements? Slow movements are what? You fix it. Suppose a person enters, I fix him. The person moves, I have to follow him. That's called pursuit. It's a type of slow movement. So what is the role of slow movement? Again, the stability of the images in the retina. They have to remain stable. That's the importance of the slow movements. There are different types of slow movements. Most important you are supposed to know is vestibular systems, pursuit systems, and vergence systems. Of course, neural integrators can be studied, but basically pursuit and then vergence system. These are all slow movements. In nystagmus, if we have, we can call it as, these are called common terminologies. Pendular. Pendulum is what? Phases of equal velocity, both sides. Jerk. Phase of unequal. One side may be fast, one side may be slow. Like that we have got. That's called jerk nystagmus. These are all the basic terminologies as far as nystagmus is concerned. Then direction. In the case of jerk nystagmus, you have to tell the direction also. Always remember, to tell the direction nystagmus, you have to see the fast phase. Suppose the fast phase is towards the right side, you tell right beating. Fast phase towards down side is called down beating. That you have to depends upon the fast phase only you have to tell. But the beauty here is what? The nystagmus problem, actually the pathology is lying in the slow movement. The fast movement is only a correcting movement. Never forget that. The plane, the nystagmus can be horizontal, vertical, or torsional, oblique, whatever different types of circular. So different types of plane. When you see a nystagmus, you see, is it moving only horizontally? Is it moving vertically? That you can make impression. You can write your diagnosis, you can write your findings, then you can come to a conclusion. When you note about the nystagmus, you always tell what's the amplitude of the nystagmus. What do you mean by amplitude? How far the eyes can move. How far the eyes can move is called amplitude. That's called fine, moderate, and large. Frequency, how rapidly the eyes moves. How rapidly the eyes move. We got slow, medium, fast. This is a way out right. Nystagmus, a fast is a fine amplitude nystagmus or a moderate amplitude. Similarly, the frequency is a slow frequency, medium frequency. Like that you have to write in the case sheet. Now they will ask you null point. What is null point? Where the eye patient can adopt some head posture or something to move the eyes in particular directions so that the amplitude in nystagmus can be reduced. That is called the null point. This will come to picture when you make a treatment choice. See, in surgery, in eye surgery, suppose I want to do any surgery for nystagmus. Our aim is to bring the null point to the primary position. Suppose null point is my convergence, I have to make it to bring it to primary position. That is the aim of your nystagmus surgery. Suppose I think some PGs are watching, so naturally they should know the null point where the amplitude is less. Our idea of doing surgery is to bring the null point in primary position, which then you are supposed to know. So can you see now equal oscillations called pendular nystagmus is called pendular, equal amplitudes. Horizontal here, the fast phase is towards the left side, it's called left beating nystagmus, left beating nystagmus. The down beating, can you see this? The nystagmus fast phase towards the downside, down beating nystagmus. Rotatory, slight movements, can you see the rotations called rotatory nystagmus? These are all the different types of nystagmus you can tell. Now, how will you classify nystagmus? Physiological. Normally, you can have nystagmus, that is optic nystagmus. Everyone knows that. Suppose one object comes there, you fix it, and the object is moving or following, the object disappears. Again, the eye comes back to take up the next object, incoming objects. That is called optic nystagmus. What is vestibular apart? Everyone knows when you inject a cold water or a warm water into the air. Now you can have nystagmus developing cold water opposite. Opposite means what? The fast phase towards the opposite side. Warm water, same. That means what? Same means what? The fast phase towards the same side of the warm water injected here. That's all. This is called as COS. Everyone knows that. Now I have to ask a question our students, sometimes our students, when you inject cold water into right ear and the left ear simultaneously, what will happen to the eyes? What type of nystagmus you can get? I have seen that many of the students may not be answering. They have to remember one clue called CUP, C-U-P, CUP, cold water up nystagmus. That means what? Warm is down, that's all. So like COS, we have got C-O-W-S, the mnemonic. Similarly, we got CUP, cold water up, that's enough. That's what is called cold water both ears. We are injecting, you can have up nystagmus. This is called animated. You can see the pursuit, slow movement going, and they come back fast. This is called animated optic nystagmus. I must thank Dr. Rajesh Sukumaran for these slides and all. He helped me a lot. The I think scientific chairman, previous scientific chairman of KSOS. This is called optic nystagmus. You can see a fast phase and a comeback. This is called as optic nystagmus. Always, one pursuit, one slow. But what's the importance here? What's the importance here in optic nystagmus? See, we got pursuit. Pursuit memory is there. That means what? An object is gone to my occipital lobe, visual cortex. I am following the first object. That means I need the eyes to move. Eyes have to move towards one direction. The impulse is starting from, for this pursuit movement, starting from your area 18 and 19, not 17. 17 is your visual cortex, visual area. Whereas parastriate and peristriate area, they start and they have to pass by your parietal lobe and come to my pons, the lateral gaze center. Then when movement can get initiated. Once you go to my occipital visual cortex, eyes I have to pursue means I have the for pathway starting from your 17, 18 and 19 area, passing via parietal lobe and come to my lateral gaze center. Then only I move eyes. Imagine the plight. When I have a problem parietal lobe, when I have a problem in the parietal lobe, that pathway is affected now. I cannot move my eyes. That's why classical again. Importance of optic nystagmus, if you want to know. The optic nystagmus, you cannot elicit when I rotate a drum in front of the patient. I cannot elicit optic nystagmus. It will be absent in a case of parietal lobe always. Always in parietal lobe is absent. Whereas in occipital lobe, if a visual that is area 17 alone getting involved, I cannot have me agreed, but still I can find out the nystagmus. I can elicit. This is the importance factor everyone should know. And one more, if a tumor lesion affecting 17 area, imagine now 17 area tumor is there. That is striate cortex. We have got the same tumor. Today I'm examining optic nystagmus, the drum test. I can see the nystagmus where the tumor, they can easily spread. They can involve even 18, 19 in future or even parietal also. So in future, you can have involvement. That's what the dictum is called, Kogan dictum. What is Kogan dictum? A tumor lesion affecting area 17. Today I can see the nystagmus, and after few months it may not. Imagine it's a case of vascular lesion involving 17. Today I can see if it's a vascular lesion, in future also I can see because it's territorial. The 18, 19 may not be affected unless a second lesion comes to affect that 18 and 19. That's what the importance of this optic nystagmus. So optic nystagmus in parietal lobe always absent if an involvement of there. Whereas an occipital lobe need not be always. Depends upon the tumor lesion and vascular lesion, they can have difference. Now, next is what now? I told you physiological, next congenital. Congenital itself, they got motor, sensory, nystagmus and all may be associated with squint. Motor, sensory and associated with squint. Motor is what now? Immediately after birth, about within a week, you can see some nystagmus like this, horizontal nystagmus. Importance what? When you look up also, then same horizontal pattern is maintained, horizontal movement. But usually it's an autosomal dominant problem. Whereas sensory problems, I can have anterivisual pathway problem is there. Suppose a problem in the congenital cataract is there. Something problem involving macula or foveal aplasia, something is there. Patient albinism. So many patients can go in for nystagmus because why? The occipital lobe is not receiving any impulse, not receiving any sensory impulses. That's why imagine now this something they tell like this. The occipital lobe making the eyes to move, to take up or to get some impulse. That is what descriptions. The occipital lobe, the posterior visual area, making the anterior visual pathway to move so that nystagmus can be elicited, developed, and they want what of such of impulses for some sensations to reach it. Then we got what now? Considering that usually affects men between 2 and 3 months of age. Then we got cataracts, I told you, Leber's amaurosis, albinism. These are the patients may develop sensory type of nystagmus. But never forget, motor nystagmus, congenital starts in first week, whereas sensory nystagmus starts in second and third months. I already told you pendular nystagmus, equal oscillations. Later nystagmus, when you have classically a spin problem is there, infantile esotropias. Of course, not an infant patient. Just I'm telling now, it's a demonstration only. Twin case infantile esotropia patients can develop latent nystagmus, or they can have manifest latent. You see here, when you cover, amplitude is increasing. When you uncover, see now, that means no nystagmus. It's called latent nystagmus. It's called latent, means what? Only when you cover one eye, the nystagmus is coming out. Next what? Manifest latent. See now you got nystagmus. When you cover one eye, the amplitude has increased. That is what the manifest latent. This also can be a manifestation of infantile esotropia patients. Vestibular, I already told you, cold water opposite. That means even it's a physiological phenomenon. But how do you know a irritating lesion is there? A distant tumor is there. How do you know about nystagmus? Very simple. A tumor is there inside the vestibular apparatus and all. It behaves like a cold water. Just remember this. Just a tumor inside the vestibular nerve and all behave like a cold water. Whereas irritative lesions like Meniere's disease, they will behave like a warm water. These are classical, same thing only, cows. Cold water, opposite, warm, same. So it depends upon it, you can tell cold water, problem or destructive lesions. Whereas irritative lesions, you can have Meniere's disease and all, they can behave like a warm water. Now, I want to know whether it's peripheral nystagmus, vestibular area, that vestibular apparatus area, or is a vestibular nuclear area in the pons and all. Then how do you know? Just nystagmus is there, ask him to fix an object, the nystagmus amplitude will come down. That is called peripheral. When you ask him to fix, there is no improvement. It is called as central vestibular nystagmus. Very simple. Nystagmus is there, ask him to fix an object, the nystagmus will come down. When a case of central nystagmus, you ask him to fix, the nystagmus will not be diminished. Same amplitude, everything will be there. One more question you can now, when a case encounter a case of nystagmus, both, of course, everyone knows congenital, recent, vestibular or neurological problems. You know that. But normally we ask questions, how do you know usually it's congenital? Or how do you know usually it's an acquired nystagmus? How do you know that? Just by asking one question. Of course, usually, I'm telling you, not always. Usually, a person having nystagmus from younger days or birth onwards will not have oscillopsia. That means the environmental objects will not move. Whereas an acquired nystagmus, recently acquired nystagmus, will develop definitely oscillopsia. When you have movements outside where environment is moving, naturally what? We will have vertigo, you will have giddiness, nausea, vomiting, all sorts of problems will come into picture. That is what the difference between congenital nystagmus and acquired nystagmus is. Just one question to the patient. Your question should be oscillopsia. That's all. Are you experiencing outside world is stationary or moving? That's the question you are supposed to ask to the patient. You can come to a conclusion straight away. Which is all I told you. This called oscillopsia. See, the person is there, and the person will be seen as is moving. Oscillations. When you examine visual acuity, of course, then you should know nystagmus you have to move. Nystagmus, what is it? Pendular nystagmus, or is it a jerk nystagmus, or is it beating which side? Is it down beating, up beating? Whether you have to measure, you have to tell, is it amplitude is how much, or is it frequency is how much? You have to write. Similarly, any other associations are there. Associations like head nodding, head positions. If head position, suppose I turn my head to a right side, nystagmus is blocked. That means I know the patient can adopt head posture towards right side to bring down the amplitude. That is called approximately null point. That is where the surgery also goes in. Now we have got other associations, like you must note down. Head oscillations, is it there or not? That's called, everyone know that. Head spasmus mutans, that's called head oscillations will be there. Head positions are there. You must note down the patient apart from noting down the nystagmus. See now, I told you. One more thing, if you just by seeing nystagmus, the direction nystagmus, you can fairly come to a conclusion of the location or the site of lesion. You can come to a conclusion. See now here, downbeating nystagmus. When you have a downbeating nystagmus, see here, when you have a downbeating nystagmus, the herniation. Herniation is there. Can you see this? Herniation of tonsils of cerebellum. That means foramen magnum area. That's called Arnold cherry malformations. So when you have a case, downbeating nystagmus, think about the possibility is there, Arnold cherry malformation is there. That's why accordingly you see, note down, you can tell the neurologist, sir, this is a case I'm seeing now. I found out now probably Arnold cherry malformations. Please rule out. You can refer that instead of telling the patient directly. Upbeating, same thing only cerebellum problems. Cerebellum problems can have upbeating nystagmus also. Other conditions like ophthalmological problems like reverse amaurosis, they're different. But at least know that just by seeing upbeating, I know cerebellum problem is there. Like that you can brain some problem is there. Like that you can at least come to a conclusion, then refer the patient. Rotating nystagmus. Seesaw. See, one eye is moving up, other eye is coming down. It's called seesaw nystagmus of Maddox. Seesaw nystagmus of Maddox. When you have this problem, think the problem may be somewhere around the chiasma. That's all. Parachiasmatic area, seesaw nystagmus. Now, if you see a person like this, you make a diagnosis of seesaw nystagmus. Enough. That means one. Accordingly, you can investigate for the problems of the patient. Retracted nystagmus. You know, if I got a pineal body tumor is there, they can compress your dorsal midbrain. That is called Paret syndrome. What's happening here? Now we got, you know, the dorsal midbrain has got your pupillary pathway, mainly light reflex pathway. Whereas the accommodation pathway is a ventral portion. That is why normally the problem in the upper aspect, dorsal midbrain syndrome, pupil light reflex will be absent. You can have what is called light near dissociations. At the same time, your vertical gaze center also is there. Vertical gaze center is also there, which can involve your guttils. Vertical gaze center, the vertical gaze palsy will be there. When you try to move the eye downwards or something, you can see the muscles are working, but only they is not getting coordinated. The eyeball is going backwards. It's called retraction nystagmus. This is also a classical feature of when you have a retraction nystagmus, think about the possibility. A patient can have a dorsal midbrain syndrome. That you can think. Here you can see now, right eye not adducting, the left eye is abducting. You can see nystagmus. This is called one eye shows nystagmus. It's called dissociated nystagmus. You know that what is that? Now the right eye not able to adduct, whereas the left eye able to abduct, not able to maintain. That means what? A problem somewhere in the medial longitudinal bundle. The medial longitudinal bundle connecting with 6th nerve nucleus, the 3rd nerve nucleus. That bundle has got some problem. That's all. That communication is not there. So the left eye here abducting, that means 6th nerve is okay. But the impulse has not gone to my right side. The 3rd nerve is not adducting. Middle neck is not adducting. So naturally, we got a test to come back and we come back and all. Everything that's called dissociated nystagmus. Now you know the problem somewhere in maybe in the middle longitudinal bundle. That's all. You can tell maybe upon midbrain depends upon the other problems like convergence and all. Now we have got question is what now? Very important. Whenever you see internuclear ophthalmoplegia, or whenever you see a bilateral internuclear ophthalmoplegia, whenever you see a 1.5 syndrome and all, first thing you are supposed to rule out is multiple sclerosis only, or intrinsic lesions of pons and midbrain area. Whereas pseudo internuclear, pseudo INO, always think myasthenia. So myasthenia is always a great mimicker. Never forget that. I always tell our students, when you're in doubt, when you're not able to come to a conclusion regarding the etiology or regarding some problems in the making diagnosis in neuro ophthalmology, you tell, I would like to rule out myasthenia. But myasthenia, you should know how to rule out. That's the most important thing. But you must know myasthenia to be ruled out. Any patient that can mimic any problem in the neuro ophthalmology cases. This is what the practice going on. Meeting now we have got to dance practice. This is called the movements practice, eye movements practice. That's what's happening in our land of God. Thank you very much.
Thank you so much, Dr. Vijayaraghavan. It would be presumptuous on my part to praise your talk. All of us know what an excellent teacher you are. Instead, let me thank you for clarifying nystagmus for all of us. When I was asked to chair this session and I looked at the two keynotes, I thought, well, ocular palsies and diplopia, everybody has some idea of what it might be and how to go about it, but I'm sure there'll be extra points that we pick up. When I looked at the second keynote, and like in your first slide, I thought everybody will say, oh my God, nystagmus, because most of the time we have no clue how to, what causes it and what manages it. So you've told us the types of nystagmus, the relevance of nystagmus, the causes of nystagmus, and I'm sure it's clarified so much for so many of us. Thank you.
Thank you, madam. Thank you.
We'll straight away go into the next session, that is session 4. The chairperson will be Dr. Vijayaraghavan sir, and the panelists are Dr. NSD Raju sir and Dr. Padmaja madam. And the keynote on visual hallucinations and illusions, are they diagnostic? The speaker will be Dr. N.V. Francis sir. Over to you, Francis sir, please.
My slide is visible?
Yes, sir. Yes, sir. Yes, sir.
Okay. So good afternoon, everyone. And thanks again, Dr. Arun, for this invitation. Visual hallucinations and illusions are not uncommon in daily ophthalmic practice. When they come, they can be really challenging. And many patients underreport this because of the stigma associated with it. They are considered mental or crazy. Hallucinations are nothing but visualizing something which is not there. And illusions are misperceiving objects. Objects are there, stimulus is there, but patient is misperceiving. We can broadly group them into 6. The most important is diagnostic hallucination. A single visual symptom can become diagnostic of a disease. Second is diagnostically useful. Third, related to CNS, psychiatric and systemic disorders. Then medications and psychoactive drugs. And local origin hallucinations arising from the eye structures. And it can be benign in anyone when under stress, anxiety, sleep deprivation, hunger, and certain dietary substances. And the commonest, as we know in any clinical practice, is migraine aura. Migraine is visual hallucination. Studies are showing up to 30% of migraineurs can get hallucinations, and 95% are visual hallucinations. So how to diagnose this? To diagnose this, you have to dissect it, cut it into pieces. You get 3 out of 6 pieces, you diagnose migraine aura. The most important is gradually developing visual hallucination. Padukke padukke, savadhana, melle melle. That is the most clinching diagnostic evidence. Second is duration, 5 to 16 minutes. Third is positive visual phenomenon, not negative. Fourth is unilateral. Fifth is any headache. You don't have to get migraine headache. Any headache is okay. And last is 2 or more hallucinations occur in succession. First visual, then sensory, then speech. Always you have to get 2 episodes to diagnose migraine aura. This is the Indian aura documented by patients. And this is the Western aura, more artistic. You can see the slow expansion of the zigzags and the cloud-like formation. And these are other pictures that my patients have drawn. Bubbles in the air, leaf movement, boiling oil, ECG-like. So anything you can get. And when you have this duration of 5 to 16 minutes, you have some differentials. And which are those differentials? You can divide them into 2, age above 50 and age below 50. Above 50, the most important is transient ischemic attack, vertebrobasilar insufficiency, usually negative, sudden onset, without any migraine aura or migraine history in the past. But a positive visual phenomenon is always possible, classically described as snow falling through the beam of a headlight. Second is cerebral amyloid angiopathy. That means they get visual aura, like migraine aura, like continuous visual phenomena. And that time you must go for blood sensitive MRI that will pick up microbleed. They will have microhemorrhages and lobar hemorrhages. And ocular ischemic syndrome, so-called venous stasis retinopathy, again negative, but you can get a positive tinge. They can last up to 10 minutes and they can develop slowly like a migraine aura. Less than 50, you have the retinal migraine, The difference between typical aura migraine and retinal migraine is that in retinal migraine, the entire visual field is having scintillation. And in typical aura, it is only the temporal or nasal region. Then the second is venous congestion, secondary to hypercoagulable, hyperviscous state. And you know how to investigate. And these can last up to 20 minutes. Again, usually negative, but positive visual phenomenon recorded. And the last is Alice in the Wonderland syndrome. That is a migraine variant usually, and they are migrainous illusions. Patients get misperception of their own body or the surroundings. You can see the plate is broken, the glass is bent, and the flower has a halo. And any such strange phenomenon can occur. This is vertical split or horizontal split known as prosopometamorphopsia, and this is, face in the cloud, that is pareidolia. And you can get macrosomatognosia and microsomatognosia. A limb is enlarging, limb is shrinking, head is bloated up. So all these are possible in this Alice in the Wonderland syndrome. So how do you diagnose? One is it is a positive visual illusion. That is like a migraine aura. Second is the duration, 5 to 60 minutes. But the more important is the triggers precipitating it, either a single migraine trigger or combination of migraine triggers. And you get a family history of migraine, more of mothers. Then they are absolutely normal after each episode. That is also very important. They are nothing else after the episode is over. They sleep, they take rest, and they are absolutely normal. And some of them can get something known as episodic syndrome, non-headache migraine manifestation in the childhood. They can get recurrent pain abdomen, recurrent vomiting, and recurrent giddiness or dizziness. So it is persisting for more than 60 minutes, prolonged visual hallucination. So if it is migraine origin, developed slowly, then immediately one must rule out migrainous infarct. So you go for diffusion weighted MRI. Then second is outer retinal dysfunction, the photoreceptors and the retinal pigment epithelium, which can scintillate when it is hyperpolarized. Usually they are in a depolarized state, so you don't see any light. Whenever there is inflammatory insult or a metabolic insult, like in toxic neuropathy, paraneoplastic neuropathy, and degeneration like RP, retinitis pigmentosa, and Azure syndrome, presumed inflammatory syndrome, where the prominent one is acute idiopathic blind spot enlargement, where they get a scotoma in the visual field and surrounding scintillation. Or they get scintillation first, then scotoma. They are more in the young female patients, healthy patients. So they are, diagnosed as migraine aura. Then when you get prolonged aura and mood disturbances, you can think of an extremely rare condition known as CADASI, cerebral autosomal dominant arteriopathy, subcortical infarct, and leukoencephalopathy. And when they have a facial hemangioma, port wine stain, and prolonged aura, you can always consider Sturge-Weber syndrome type 1. And there is an extremely rare headache syndrome known as HAND, transient headache neurological deficit. That is this visual aura, which can be prolonged more than 24 hours. But for that, you have to diagnose by doing lumbar puncture. They get lymphocytosis, usually self-limiting. Within 2 to 3 months, it subsides completely. And if it is bilateral and persisting, then you have this rare condition known as visual snow. You can see the picture there. This is what one youngster drawn about his visual snow, which must last more than 3 months. And classically, it is the TV static. Whenever there is power cut, you know how the TV screen looks like. And they also get 2 more additional hallucinations. One is palinopsia, that is you remove an object, still the patient can perceive the image there. Second is enhanced endoptic phenomena. You know that, enhanced endoptic phenomena. That is why I call it a chaotic visual hallucination. In enhanced endoptic phenomena, they see numerous uncountable dots and specks, colored, brightly illuminated, black and white. And also they see excess flashes and excessive floaters. And when they close their eyes, they get that self-lighting. That means clouds and waves passing in front of their visual field, shooting across. So you can get all type of unformed hallucination in this condition. Previously thought of migraine origin, but now PET scan showing hypermetabolism in the lingual gyrus. So it is considered a different entity. Now, if it is less than 5 minutes, by this 5 minutes duration, if it is less than 5 minutes, brief, lasting seconds or minutes, then you have the seizure hallucination, classically known as gestalt benign occipital epilepsy. They get colored hallucination lasting only seconds. You know, they move from temporal area to nasal area. Migraines move from central area to temporal area. And they are colored always, pinwheels, bubbles, like that. And 50% of them get migraine headache. That is why the confusion between migraine aura and seizure aura. And you can also get ominous aura, not always benign. This is, you know, occipital region, AV malformation bleed, and cavernous angioma bleed. Now, when you suspect a seizure, because brief hallucinations possible in migraine also. So that is why you have 6 neuroocular symptoms and signs. If you get one symptom or one sign, then you can always diagnose a seizure episode. That is blank stare, staring into the atmosphere at that time of the aura, forced eyelid closure, lid fluttering, gaze deviation, and epileptic nystagmus and mydriasis. So if you get one of these symptoms, some of these symptoms only family members only notice, so you can instruct them to observe whenever they have another episode. And we also know that seconds of hallucination, flashes, flickering possible in embolism. Again, negative curtain shadow, but any ischemic process, you can get a positive tinge. And papilledema, especially when postural, bending and getting up, one can get flashes of scintillation. And ONH anomalies and retinal vasospasm. They are all, you know, seconds or maybe 2-3 minutes. And somebody getting daily hallucination, migrainous hallucination, starting slowly, then you diagnose that as aura status, and you can treat it as the way you treat any recurrent migraine attack. And if it is not a migraine type hallucination and they are getting it frequently, then you have 3 important differentials: carotid dissection, reversible cerebral vasoconstriction syndrome, a rare headache syndrome, and RPLS, reversible posterior leukoencephalopathy syndrome, usually due to malignant hypertension and in pregnancy and postpartum. Now, movement-evoked hallucination, you know that PVD is very familiar with you, and RD, rarely RD, retinal detachment, and mood lightning streaks. Rapid movement to the right temporal side, especially in the dark or dim illumination, they get a vertically oriented flash. And whenever you get painful hallucination with eye movement, it is retrobulbar neuritis or optic neuritis. You know Charles Bonnet syndrome, a partially blind, a blind patient getting complex hallucination. But always remember, same hallucination can be there for a peduncular infarct, cerebral peduncular infarct, midbrain infarct, or in a thalamic infarct, and any posterior visual pathway infarct. So always see that you are not missing it whenever they come with, or whenever you diagnose Charles Bonnet syndrome. And another important entity which you can diagnose from hallucination is narcolepsy. Usually these narcolepsies are missed. They come to you with sudden sleep attacks. When they read, when they write, they suddenly fall into sleep. And that are very short spells, 10 minutes or 30 minutes. So naturally they think this is an eye problem, a spectacle problem. So that is the time you ask about 2 hallucinations. One is hypnagogic hallucination. That is when they fall into sleep, they get complex hallucination, visual hallucination, and hypnopompic, when they are getting up, awakening hallucination. So if you get this with a history of sleep attacks, that is nothing but narcolepsy. And they can also get sleep paralysis. When they get up early morning, their limbs are not able to move, and it takes some time for them to get up. And another symptom known as cataplexy, that is sudden loss of muscle tone. They can fall all of a sudden. So all this will help you And more importantly, it is the hallucination along with sleep attacks. You diagnose narcolepsy. And medication and recreational drugs, psychoactive drugs also can cause visual hallucinations. So that is why take a detailed history of all the drugs that they have taken, even in the past. Some of the drugs, even after you discontinue, they can get hallucinations. So antidepressants, anti-Parkinson's, anticholinergics, erectile dysfunction like sildenafil, cardiac drug like digitalis, and those hallucinogenic drugs, LSD, MDMA, cocaine, and marijuana. And presence and passage hallucination. In Parkinsonism, many patients, up to 60% of the Parkinson patients get either presence hallucination or passage hallucination. Somebody is present in the room on her side or in the back, or somebody is passing by. So they are very brief, seconds only, usually localized in the periphery. It can be shadows, cats, and dogs, usually after 1 year into the disease process. So it could be due to the medication also. It's not very easy to differentiate whether it is the disease process or medication. I do get this once or twice a month. Then you also have these two rare conditions. One is dementia, Lewy body dementia, and schizophrenia. One before 50, one above 50. During the prodromal stage, they can come with visual hallucination. So be very careful, and always, when you are suspicious about hallucinations, ask about cognitive symptoms, attention, orientation, memory, judgment, and something about mental health. Or if you are so busy, you can ask them any aging symptoms. Some of the symptoms are considered aging, or any unusual symptoms. So the family members will come out with some early symptoms that they notice. These symptoms are always subtle, so family have to be contacted. And you can also ask about any other hallucinations like auditory hallucination going in favor of a schizophrenic process. Now, to conclude, visual hallucinations and illusions alone are diagnostic in some brain syndromes. They also help in diagnosing some other CNS dysfunctions like narcolepsy. Dissect visual hallucination to diagnose the commonest migraine auras. If it is persisting, migrainous infarct, posterior visual pathway infarct, and peduncular infarcts, visual snow, and outer retinal dysfunction are differentiates. Before diagnosing CBS, rule out PVP infarct, posterior visual pathway infarct, and peduncular hallucinosis. Brief colored hallucinations can be seizure in origin. Narcolepsy must not be missed. Inquire about hypnagogic and hypnopompic hallucinations. Details of medications or drugs can be diagnosed. Lewy body dementia and schizophrenia may initially present with visual hallucinations. Presence and passage hallucinations are common in Parkinson's disease. Thank you. Thank you very much.
Great, sir. Francis, sir. Fantastic lecture. Really, I think you are an authority on these hallucinations and all. By few points I can tell. So the sildenafil, you told about sildenafil hallucinations. And because of inhibition of the phosphodiesterase 5 and 6, the patient can go in for blue vision after some time. Is it a hallucination or not? Because they experience blue vision after sildenafil. Can it be hallucination, you call it as, or just a visual problem only?
Sir, I didn't listen to you. Can you please repeat it?
So sildenafil.
Yeah.
You told about hallucinations experience,
Yeah.
And sildenafil is a phosphodiesterase 5/6 inhibitor.
Yeah.
So naturally, what happens? The patient can experience blue vision. That's called a blue vision problem in the night time.
Yeah.
Is it a hallucination or is it just a visual problem? Different.
It is an unformed hallucination, sir.
Okay.
Like you get in visual snow, and even in epilepsy, seizure, you can get unformed hallucination.
Achha.
And of course, digital is causing xanthopsia.
Yellow vision.
Yellow vision, yeah.
Yellow
so
vision.
I think they are all considered as hallucinations because they are not there in the visual field. So I think they are considered hallucinations, unformed symbol hallucinations.
So one more you told, sir, nicely, that is a transient hallucinations can occur in papilledema. You told, no, sir. Transient hallucination in papilledema patients.
Yeah.
You
Flickering
told.
and scintillation, extremely rare.
Because I have heard.
When postural, bending and getting up.
That is
or
what.
Valsalva.
That is what we can, sometimes we can have a tumor inside the third ventricle. It's called ball valve tumor, which can obstruct and something, third one, that's an aqueduct. Sudden increase of third ventricle compressing chiasma, getting released, the chiasma compression lost. That's one of the causes for transient obscuration of vision, loss of vision also. That's also one of the causes told.
That also, when I teach, I said papilledema symptoms. I teach headache to non-ophthalmologists without any ophthalmoscope. So I tell them to look for papilledema symptoms, transient blurring, transient diplopia, and pulsatile tinnitus. So without ophthalmoscope, they can suspect a papilledema process. Yeah.
One more, formed objects and unformed objects hallucinations. Formed objects hallucination more common with the temporal lobe. Yeah, unformed objects common in occipital lobe. This also can give us a clue regarding the site of lesions.
Yes, yes. That
so
is why
thank you very much.
Okay, sir. Alice in the Wonderland syndrome, temporal lobe epilepsy is a differential. Thank you. Thank you very much.
Thank you very much, sir. Francis, sir. Thank you.
Thank you. Thank you, sir.
Dr. Francis, I have one question about
okay, sir.
The occipital strokes, what are the characteristic features of the occipital strokes? They are formed hallucinations, colorful ones, or
yeah.
Can you just give a...
I have seen many cases where they can come with complex hallucinations. Actually, complex must be with the surrounding area, parieto-occipital or temporo-occipital. But I have many cases where they get up early morning and they say vessels tumbling, snakes moving, and imaging showing occipital infarct. So they can also present with blurring of vision. And that is why always when they present with recent onset, sudden onset hallucination, whether it is simple or complex, go for a visual field, minimum confrontation visual field, if autoperimetry not available. So both complex and simple hallucinations can occur in occipital infarct. Of course, this is not well understood why occipital lobe, where only vision is represented, one gets complex hallucination. Maybe some relation with the temporal lobe and the parietal lobe, which we do not know actually.
And what about the post-ictal hallucinations? Do they have any characteristic feature? The post-ictal
after epilepsy.
Yeah.
After the epileptic attack.
Yeah.
Post-ictal headache is there. Post-ictal hallucination, I do not know. I have heard of pre-ictal, ictal, and post-ictal headache, and always hallucinations are during the ictus. So whether it can persist, yeah, I think there is a possibility it can persist.
I have heard about that because.
But generally, very brief, seconds or maximum 2 to 3 minutes.
Sir, I have a doubt. It's rather a query. I have a patient with end-stage ARMD, age-related macular degeneration.
Yeah.
And patient's vision is very poor, cannot do anything about it, but she's getting something like Charles Bonnet syndrome hallucination. Yeah. So is there something, imaging is normal, is there something that we can do to reduce the hallucinations?
What you can do, actually, one they say, tinted glasses for this Charles Bonnet syndrome, and also adjust the illumination. Ambient illumination you can adjust, and you can try cognitive behavioral therapy and transcranial magnetic stimulation. Both have been recommended for CBS hallucinations. And drugs like, SSRI, SNRI, selective serotonin reuptake inhibitors like fluoxetine, and SNRI, duloxetine and venlafaxine. They are considered to be helpful for Charles Bonnet. Yeah. Okay. And of course, any cataract or anything else which you can, tackle, try to,
Not possible.
Otherwise, it is very difficult. But generally, they get adjusted. They have the insight and they get adjusted to that. Yeah.
Something you said about light, like if the person has a habit of sleeping with the light on, you should ask them to reduce the light. Does that make a difference?
There must be, I think depending on their complaint, there must be good illumination for them. Or if the illumination is causing the problem, you can try, less illumination, you can close the window. Yeah, and more importantly, what I have seen from my experience is a proper sleep. Whenever there is sleep disturbances, their hallucinations increase. Stress and right time food, like the advice I give for migraine patients. So sleep is very important. And there are studies where they say in occipital infarct, sleep deprived patients get more hallucinations than people who sleep normally. Yeah.
Thank you.
Thank you very much, sir. We now go to a case presentation.
The next case presentation is by Dr. Donna Matthew. Dr. Donna is consultant oculoplasty and neuro-ophthalmology at Little Flower Hospital, Angamali. Over to you, Dr. Donna.
You have to open your slide presentation, Dr. Donna. Yeah, you can go ahead. Are you on mute? We can't hear you. I think you're on mute. Yeah, I can hear. You can go ahead.
Okay. Good afternoon, and I thank Dr. Thomas Arun for this opportunity. So this is a case of 68-year-old male who presented with the sudden onset of defective vision in the right eye of 1 week duration with history of headache and diplopia of 1 month duration. So he developed a right-sided hemicranial headache along with a right upper lid droop 1 month back, which was constantly in nature, and a binocular diplopia. So in few days' time, he developed a complete ptosis and his headache worsened, and he met a physician, and a CT brain was done, and it is reported normal. So he was diagnosed as a case of pupil sparing third nerve palsy and was advised steroids. After 1 week, he noticed a drop in right eye, and he met an ophthalmologist, and then he was diagnosed as a case of third and sixth cranial nerve palsy. She advised an MRA brain with contrast to him. When he didn't do that, in 1 week review, his vision had dropped to CF, and he was referred to us. There's no history of trauma, tuberculosis, herpes infection, or any malignancy in the body. There's no neurosurgical procedures done, and there's no history of recurrent sinusitis. So he's a non-diabetic and hypertension since 5 years on irregular treatment with poor diabetic control. Ocular examination, he had right eye mild ptosis with an XT of 15 degree. Extraocular movements were limited in right eye in all gaze, and intrusion was absent. So his ptosis, he had ptosis, vision was CF, and his right corneal sensation was reduced, and pupil, he had a grade 3 RAPD, and lens was cataractal. Left anterior segment was normal except for a cataract. So IOP FT was normal. The fundus, both eyes was normal study with margins defined. So his pulse rate were normal. So cranial nerve examination, his mental functions, and there was no normal, and there was no neurological deficit. So cranial nerve examination, we had an involvement of second, third, fourth, and sixth cranial nerve, along with ophthalmic division of trigeminal nerve. V2, V3 were found normal. There was no nystagmus, and there were no involuntary eye movements. So considering this, we took it as a professional diagnosis of a right orbital apex syndrome. So an MRI brain with orbit was advised. So on MRI orbit, we could see that his left, this is the left sinus, sphenoid sinus, which was normal, but in the right sinus, there was an involvement of mucosal thickening, and there was an abnormal soft tissue thickening at the orbital apex, and which was enhancing with contrast. So other blood parameters were normal except for a high blood sugar level. So MRA was suggestive of an orbital apex symptom, a lesion involving the orbital apex, probably due to sinusitis in the sphenoid. So after discussing with the radiologist whether can it be a fungal etiology, and the radiologist said that it is very unlikely to be a fungal etiology. So we started the patient on systemic antibiotics and steroids. So a nasal ENT consultation was sought, and a nasal endoscopy was performed, and a sphenoid ostium was found blocked. But this patient had been recently started on clopidogrel, so we couldn't do a biopsy. So neurology consultation, they said it is consistent with the right orbital apex syndrome. So on review, in a 1 week span, there was a considerable improvement in his vision to 618 NIG, and his extraocular movements were improving. So we did test CT, PNS. Then that was also found that the lesion, the sinusitis, everything resolved in a 1 week span. So this is the case of orbital, but it was a very fast recovery with a good improvement in vision. That's it. Thank you.
Vijayaraghavan, sir.
Yes, sir. That is why radiologist diagnosed fungus and all? I do not know. Fungal infections. Yeah. Any reason to? You are told radiologist has told it's not fungus.
So we wanted to start him on steroids because we were not sure, because it is commended in the radiologist probably it can be a fungus etiology. That was the diagnosis by the he came in casualty at night, so we didn't have any provision for an endoscopy immediately to be done. So that is the reason we had to discuss.
Okay. You started any steroids? No, not yet.
Yes, we started him on systemic steroids and antibiotics.
Okay. Okay, Matthew. Thank you.
Thank you, sir.
Sir, can I add a comment?
Yes, please.
Stop sharing.
Yeah, allergic fungal sinusitis is pretty common cause, seen, which can produce this sort of a picture. I've also had many patients with allergic fungal sinusitis coming and presenting either as optic neuritis or as multiple cranial nerve palsy. Now, but very important thing is to distinguish it from an invasive fungal sinusitis. I don't know whether this was fungal sinusitis, but considering the fact that the radiologist thought it was fungal and it improved with steroids, if it is fungal, it could be allergic fungal sinusitis. That's why it responded. But the diagnostic thing would have to be an ENT person should have done a biopsy if it was possible to distinguish it, whether it was what was the nature of the lesion. Because AFS will definitely improve with steroids. But if it's an invasive fungal sinusitis, then you are in a very dangerous situation because steroids will make it worse. So that's the thing. Usually you saw it with COVID infection and mucor and all those conditions. So in that case, the biopsy will only show whether the sinus mucosa is affected or not. And that is the diagnostic criteria for an invasive fungal sinusitis. So in this case, it could have been anything else, anything, no TB, sarcoid, everything was ruled out, no?
Everything was ruled out. ACE was normal.
But in AFS also, it responds very well to steroids. But along with that, the ENT surgeon usually does a FES and removes the bulk of the, the load from this thing. But in your case, it went off on its own. So it could have been anything else also.
Biopsy was not done because of the clopidogrel.
Yeah. Yes, it was deferred.
Answer, sir?
Yes. Yes, sir. Arun Varghese, sir, your talk.
So now just a short short talk on recent advances, sir. Just a very short talk, and then after that we'll conclude this session.
Recent advances in neuro ophthalmology, a talk by Dr. Thomas Arun Varghese. Please, sir.
visible? Is it visible?
Yeah, but slideshow has not been enabled.
Now?
Yes.
Good afternoon, everyone. We had a long morning, so we're coming to the end, and just a short summary on a few of the recent advances in neuro-ophthalmology. Some of these actually have been mentioned already in today's talks. So I've just had a few headings. One is on imaging advances. One is on novel drugs and stem cells. Artificial intelligence, as you know, artificial intelligence is there now in all fields of life and apps in neuro-ophthalmology. Dr. Virender has covered the corona-related aspects and also optic neuritis, so I wouldn't go into that. So imaging advances, as you know, we are now using MRI. Now there are new developments and software in MRI. One of them is this diffusion tensor imaging, and this is mainly used for tractography. So this mainly, for example, in the case of neuro-ophthalmology, the imaging of the visual tract. So all the way from the optic nerve to the chiasma, the optic tract, and also the visual radiation, and all the way to the occipital cortex. So this technology uses the way the water diffuses inside the tissues. That's why it's called diffusion tensor imaging, and it's mainly for imaging white matter. So the visual tracts are ideal for this sort of imaging. And the main use in the case of neuro-ophthalmology would be for imaging of the optic radiation and also the Mayer's loop. Sometimes, so the advantage is that sometimes when you say a patient you have, say, with a hemianopia, and you do an MRI, and MRI comes as normal. So sometimes you may have functional changes happening before actual major structural changes. And so this is something that can be picked up by this tractography. So it visualizes especially parts of the visual tract like the optic radiation and the Mayer's loop are better visualized with this sort of technology. This technology is quite expensive, and there are not many centers currently doing it now, but I think it's a matter of time, just like anything else, before this become available. Another technology that is available is that functional MRI. This has been around longer, since the late 1990s, and this is based on the flow of blood flow and the oxygen levels in the blood in the different parts of the brain. So when a particular part of the brain is working, that is, for example, you are looking at something, then your visual cortex is working. So correspondingly, the blood flow to that area of the brain increases, and that is the basis of this technology. So you, for example, just like in the case of your multifocal ERG, you are actually made to look at an image in the same way, and then the corresponding area of the brain is imaged, and we look at the change in the blood flow in that area. And again, the advantage is that you can pick up changes before major structural changes are there. So there may be problems in the functional, in the blood flow to that area before actual major structural changes actually happen. And this is mainly useful for imaging the visual cortex. And also, it also looks at the oxygen level in the different in that area. And so this is again something that is more useful. And sometimes this is something that neurosurgeons actually use. For example, in neurosurgery, certain parts of the brain they want to avoid or stay away from, and see the function of that area of the brain, sometimes actually during surgery. And this is something that is being used, and this is becoming more and more available. And sometimes the Dr. Francis was also saying, the complaints that as patients say, so you may do an MRI and not see any major structural anomalies, but you know certain with these studies we know certain parts of the visual cortex are used for certain things. For example, color, motion, recognizing faces, places, bodies, so visual words. So we now know that with this technique that different parts of the visual cortex are used for different things. So in the future, probably with the different complaints that our patients say, we may be able to find out where exactly the problem is. Dr. Virender Dr. Pradeep Sharma sir had actually briefly shown this the use of OCT to differentiate papilledema versus papillitis. So in the case of papilledema, which is the picture on your left, you can see there is a positive angle. The angle is measured from the tangential line from the globe, And then you look at the line, which is the on your left. The upper line is the line formed by the RPE and basement membrane. And in the case of papilledema, you actually get a positive angle, while on your right, the picture is the case of papillitis. Well, in the case of papillitis, you actually get a negative angle. This is probably in cases of early papilledema or papillitis, where there is a doubt which is what is happening. And here they say this can have a 96% sensitivity and 99% specificity in differentiating cases of papilledema and papillitis with this technology. Moving on to novel drugs and stem cells, I just mentioned briefly, Dr. Ambika actually mentioned the second one. You can see in this picture the use of tocilizumab in giant cell arteritis. So these are drugs which are not steroids. So the patients do not have the risk of associated with steroids, like risk of infection, risk of diabetes, hypertension, and other problems. So this actually an alternative to steroids, especially patients like giant cell arteritis who may need but long-term treatment to actually avoid not just the ocular problems, but the systemic problems due to giant cell arteritis. The drug on the top that you see is the disc thyroid optic neuropathy, where you can use new drug just come, and there have been reports of cases in actual optic thyroid-related optic neuropathy patients where they have a good response to this medication. Coming to AI in neuro-ophthalmology, these machines have been trained to recognize. So just like in the case of diabetic retinopathy, where you're taking a fundus photo, and the AI is doing the evaluation of the photo to see what stage of diabetic retinopathy is and when or where the patient needs to be referred to a diabetic retina specialist. So in the same way, AI has been used in neuro-ophthalmology, and it has been trained to again differentiate the appearance of the optic disc. So AI has been trained on 14,000 images and to differentiate whether it's a normal disc, disc of papilledema, papillitis, or other disc anomalies. And study has actually been done to compare AI versus 2 experienced neuro-ophthalmologists. And this was studied with using 800 images, 400 normal fundus, 200 of papilledema, 200 of other disc anomalies. And this was compared with 2 expert neuro-ophthalmologists. And it was found that the AI was as good as the 2 expert neuro-ophthalmologists. So this is something we look forward to, especially in areas where just like in the case of e-medicine, where just like in the case of diabetic retinopathy and telemedicine, where we don't have access to a neuro-ophthalmologist, images can be taken and can be evaluated, and the appropriate advice can be given. Coming to apps in neuro-ophthalmology, this was actually a study done. A mobile app was created with a lot of input. So this was actually a study done where the differential, the symptom, the signs, the history of the patient, all these, and also the lab test, the results of the lab test were input into the app, and based on the input, the differential diagnosis with the list of what is most likely was given. This was a study was done with neurology residents and also with ophthalmology residents, and 2 of the centers were in Kerala. One was in Srijitra and one was in Government Medical College. And the app was found to have a complementary role. So it definitely helps in narrowing down the differential diagnosis in these situations, especially for residents. So thank you. This is a very short update on what is happening in neuro-ophthalmology, and I think we are in exciting times.
Thank you very much, sir. Thomas, sir, one of the best.
Dr. Arun, I have some points in the newer development section, especially in the treatment of LSON. One is the availability of a drug called Idipenon. That has been found to be effective if administered in the early stages, and clinical trials are over, and the drug are now available for use in the LSON case, provided it is started in the early stage of 300 milligrams 3 times daily. That's one thing. The second thing is a gene therapy for the LSON. Again, it's an MTND4 gene, It is difficult for us to pass through the dense mitochondrial membrane. So we use a vector virus, and modified virus is this is fed into the modified virus, and that gets into the mitochondrial compartment, and that is has been used as a effective treatment. Initial results are very encouraging. And the third one is the transfer of mitochondria from another person, the so-called 3-parent baby, where the mother's mitochondria is removed and a new mitochondria is transferred as a donor. And this has been in practice now in Mexico, and also trials have started. So those are the few things that are occurring in the genetic gene therapy. It's also effective in this labor congenital amaurosis, where the RP gene is defective, This RP65 gene is now being used as subretinal injection, the modified one, the vector virus is injected in subretinal. That is found to have good response, especially in infants in the early stages. That I would share this information.
Great, sir. Dr. Raju, sir, one of the best this thing I've heard. And I've also heard that you told no subretinal injections of that is called Vertigene Niparvovec. That's called Luxturna. And it's available in US and all, but the cost is even a single dose cost about $8 lakh. Imagine the plight. And I don't think in India we can expect all those things in recent time. I don't think it can come in India. It's very costly affair.
But Idibenone is not very costly. I think we are going to get it in India too. That's what Rashmin told me.
Idibenone is available, sir, but only Intas Pharma is bringing out 30 milligram or 40 milligram is only available. So we need 300 milligram TDS dosage.
Yeah, 3 times daily. Yeah.
That dose is not available. We are just having something like 40 or 30.
Maybe it's only a matter of time, so that there are other things. Like in the 3-parent baby, there is a legal thing, You have a 3-parent baby, which many people probably, many countries also want. US has not given permission. India probably might, I don't know. It depends, on the countries and all. But that is I think that is a very practical way to prevent the transmission of this defective gene to the offspring.
As you rightly said, they're very exciting possibilities.
I have 2 patients with very advanced RP. I know them very, very well. I followed them up for ages. Is there anything available for them? They are virtually blind, available in India, that is. One of them is willing to spend any amount of money, provided it will work.
Same thing, but the same Luxturna, they are telling even it can work for retinitis pigmentosa patients also, apart from amaurosis Leber. This is what they are claiming.
First thing you have to do is to do a genetic evaluation and find out which gene is defective. So we have started doing with MedGenome. MedGenome is a company based in Bangalore, but they have outlets all over in Kerala for blood collection. So first thing is to do a complete retinal degeneration panel and find out which gene is defective. If it is the RP65 gene, then only Luxturna is of some use. But
there are so many genes responsible, so you have to identify that and then.
But they will identify. It is possible. We have done some LHON, like we have we are identifying the gene which is responsible, because at least now we have a diagnosis for the patient and we tell them that some new treatment may come into India, and when these kids grow up and when they become bigger and if they start a family, they ask, is it going to be transmitted to the children also? So all these are things about prognosis also we have to explain. So I have started doing gene testing, and MedGenome is one lab which does this. If you are interested.
It's happening in India also. Also, the other thing is about the dominant optic atrophy, So there the gene therapy has been tried successfully. That is the OPA1 gene that is being tried. It's also
my patient is 50 plus. His sister has a milder version of the same. He has 3 absolutely charming boys who are absolutely normal. So I was not so much concerned about the genetic basis. As he keeps asking me, doctor, anywhere, is there anything that can be done for me? He's virtually blind in that time. He's lost central vision too. Is there, I keep reading, trying. And like he says, I'm willing to do it, provided it will work.
ma'am, unless we know like all the rehabilitation, visual rehabilitation and low vision aids is what we can give. But if he wants to know about some treatment possibilities, he has to identify the gene. Because without the gene, it's not possible. Everywhere else,
Meena,
like
will
that.
the gene work even in advanced, even if the retina is gone completely? Can you reverse the process is what I mean.
P65 gene Luxturna has shown interesting results, but it is not something which translates into vision. It's something which translates into mobility and very fine changes. That's what I've understood from the papers which have described it. So many research studies are going on, but the basis of all this would be to do a genetic evaluation and find out the gene. Unless we know that, we cannot give them any further, because that's the way to go forward.
Thank you.
Meena, madam, you told something, about regarding you started giving gene therapy. What's the cost of that?
No, sir, I have I was very fortunate to listen to one of the speakers in COC last time, Dr. Ajay Vincent, who is a leading electrophysiologist from Canada. So
yeah. I also listened to that.
So he was the one who said that you should start genetic testing, and then only you identify the gene, and you look for any research trials which are going on, and you can have a tie-up. I have not started any research trials, but I have started. I have started. I called up this MedGenome, and they've given me a panel. And surprisingly, it is not that expensive as I thought. Like the entire retinal degeneration panel, which consists of more than 30 genes, costing only 14,000.
Then it'll be nice.
Yes.
Good.
So they will go and collect the blood from the patient and if anything comes positive, then they will test for the family, and we can always bargain for some concession in poor patients. But I thought that would be the start, because everywhere else, the people are going this way. Because so far we would say nothing can be done, and even if we identify the gene, nothing else is possible, and we leave it like that. But now I think with the coming of Luxturna, there is hope. So so many things in ophthalmology were really thought of never being able to come into place, and have come into place. So like that, I think we will see a day when gene therapy is really a possibility in India also. So the first step, he said, is to identify the gene and keep them in a regular follow-up, and sooner or later some new therapy is going to come, like Luxturna. But there are people who have raised money through crowdfunding, an enormous amount of rupees for treatment of other diseases. So I think the cost will come down. It's only a matter of time, and a lot of people are working on this. So as a first step, I started doing testing, and MedGenome is a lab which I have contacted. Maybe there are other labs also. They have a panel. They will come and meet you, and they will give you the panel, and the whatever you need to do. You can just request that. So the retinal degeneration contains all the genes, including the RP65 gene.
Thank you, doctor. Thank you, Dr. Thomas sir. Nice. I thank you very much for the great invitation for me. Thank you very much.
Thank you very much, sir. Thank you for the excellent talk. I'd like to thank all the faculty. Vijayaraghavan sir, Raju sir, Francis sir, Padmaja madam, Dr. Shikha, and all those who are here, and all the case presenters. Over to Shashi sir for final comments.
Thank you, Arun. I thank all the distinguished faculty, my teacher, Dr. Padmaja Krishnan, and my actually I was mesmerized by the talk by Dr. Vijayaraghavan and all the senior faculty from Kerala. The topics were planned and executed very, very perfectly by Dr. Arun. We thank our secretary, Dr. Arun, for organizing such a wonderful session. And I thank all the faculty and all the people who are involved in this from KSOS and from COC. Thank you. Thank you, everyone.
Thank you, everyone. I'd like to give special thanks to Dr. Revati and Francis sir, who are continuously guiding me all through the program and to get the wonderful faculty as well. Thank you very much, everyone. We are spot on time. I hope you all have a great evening. Thank you,
Dr. Revati, nice to see you after so many years.